Voy a mostrar mi canal de YouTube donde va. Voy a mostrar mi canal de YouTube donde va. Ok. Estamos en YouTube ahora. Ok. Déjame compartir. Mm. Mm. Ok, tú puedes ver, ¿verdad?
Sí, sí, sí.
Sí, es YouTube. YouTube. Y cuando estoy en YouTube, yo voy aquí para sacar código. Tú conoces esto, ¿verdad?
Sí.
Ok, yo saco código de allá y yo voy a poner en la página de Neurosurgical TV este código. Es la cosa más importante para mí, para hacer esto.
Claro.
Okay. Ok. Ahora estamos en la página principal de Neurosurgical TV. Tú puedes ver, ¿verdad?
Sí, 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 lo estoy viendo.
Sí. Entonces, estamos listos para estar vivo en Internet. Está vivo en YouTube, está vivo en mi página y yo voy a hacer vivo en Facebook porque yo voy a sacar, yo voy a mostrar un minuto, déjame ver. Okay. Ok, yo voy a compartir mi pantalla otra vez. Ok. Tú puedes ver mi YouTube, ¿verdad?
Estoy viendo tu YouTube, sí.
Ok. Ahora estamos vivo en YouTube. Estamos aquí. Ok.
Sí.
Vivo en YouTube. Ok, yo saca la dirección de YouTube.
Ujú.
Yo voy a mi cuenta de Facebook y mira qué pasó. Si yo pone este link, está vivo en Facebook también. Allá.
Ah, mira.
Ok, déjame ver. Sí, estoy vivo en Facebook ahora. Y esto yo para mandar, compartir en todo, tú sabes, Facebook.
Ah, entonces, claro. Y ahí donde está la parte, ahí hasta el momento es legal.
Más tarde hablamos de esto. Ok, dame un poco minutos, déjame hacer esto. Opción necesita tan buena descripción. What? Sí, un minuto.
Sí,
¿Está
sí, no
allá?
hay problema.
¿Está allá? Sí, necesito arreglar esto.
Arregla con tranquilidad. Espera.
En WhatsApp es lo mismo. Se ponga descripción, está vivo ya. Ok, tú puedes ver en mi página de Facebook. Estamos vivos con descripción y todo.
No, ahora no la tengo ahí a mano, está en tu canal, está saliendo en tu canal, así como lo tienes atrás en lo tuyo que dice Neurosurgical.
Sí, yo tengo computadoras, un laptop aquí para chequear.
Sí. Por ahora no ha ingresado nadie.
Es muy, okay. No, es temprano. Mucha gente espera hasta el último minuto.
Sí.
Uh, good day, Professor Alok Sharma.
Hello.
Yeah, hi. Hey, how you doing?
Hi. I've just connected with my chairpersons. They'll be joining in 10 minutes, sir.
Okay.
Yeah.
Very good. I'd like to introduce you to Rolando. Are you there?
I can't hear you.
Oh, you can't hear me? You can't hear me?
Hello.
Yeah,
Hello.
Rolando, can you hear me?
Rushab.
Can you hear me?
Yes. Yes.
Yeah, Rashab, something's wrong with your audio. You can't hear me, Rashab? No, something's wrong with his audio. See, little problems like this, people's head things don't work. You know what I mean? As people come in, I really enjoy, once I get everything done, I enjoy talking. Like right now, you can talk to people, you know what I mean? And you're really not, you're kind of on YouTube, but big deal. And neurosurgeons from all over the world, you're able to just talk after the show, before it. I mean, that's time that's going to be utilized in the future. This is a television technology. It's going to be like television. I mean, and you can use that for whatever you want.
Yeah. Yeah, I understand English, but I not speak very well.
Oh, I'm sorry.
My level in English is very bad for conversation.
Oh no, it's not. It's not bad.
Yes.
It's not bad. No, it's not bad. No, I have confidence. I have confidence. When I speak, cuando yo hablo español, la gente le gusta. Si es mal,
Sí,
no
claro.
importa. Ellos quieren que hace esfuerzos para hablar. Ellos les gusta. Y si da mucho, ¿cómo se dice?
Error.
Sí, flexible.
Sí.
No necesita exacto. Es lo mismo en inglés. Una persona tratando de hablar, sí, hay equivocaciones, pero está bien. La gente le gusta.
Sí.
La gente le
Sí,
gusta.
pero a veces es tan mal que peor, pero bueno. Y la gente de India también tiene su pronunciación particular.
Sí, en los Estados Unidos también, en Texas. Cuando tú oí a alguien hablando inglés de Texas,
Es terrible.
you all come round here now. You come visit us in Texas. Hay un acento muy profundo.
Sí, sí, sí.
The majority of problems are caused by poor bandwidth. But I've seen in the last couple of years, it's getting better worldwide. Internet is getting better. You can tell. In Latin America, it's getting better, especially wireless.
Sí.
In the last couple of years, I've seen it. So that there's not nearly as many transmission problems as there used to be with Google Hangout, which is the predecessor of this platform. It was a good platform, but Google really didn't take care of it.
¿Hay algún país más difícil para poder entrar en conexión? ¿Para ti?
India, algunas partes de India es mal, Pakistán también, pero ahora es mejor. Ahora India mucho mejor y Pakistán mejor. Y varias islas es difícil, pero el mundo mejorando. Yo creo sigue mejorando más y más. Con wireless más fuerte es bueno para esta tecnología. Si wireless es mejor.
Porque se suponía que India tenía mucho adelanto en tecnología. Por eso pensé que no tenía tanta dificultad.
Sí, pero tú vas a tener sorpresa. Muchos médicos famosos no tienen buen internet.
Ah.
No tienen buen internet. Tiene Wi-Fi bajo. No hay sentido en esto. Pero es algo que necesita un médico ahora, internet.
Sí,
es
totalmente.
necesario, no es una opción, es necesario. Sí, puede hacer comerciales. Por ejemplo, ayer tenía un congreso con Yuha. Mucha gente. ¿Sabes cuánto? 12,000.
12,000.
En China. En China, 12,000. Porque está televisando al mismo tiempo con translación a la comunidad de China en neurocirugía. Y Yuha es muy feliz porque él quiere enseñar a los chineses, porque antes siempre hay problema con traducción.
Y ahora hay traducción simultánea.
Sí, en el panel, el neurocirujano está allá sin voz, sin mute, está en mute, pero estoy escuchando que dice la presentadora, traduciendo simultáneamente. Y obviamente este hombre entiende la lengua de neurocirugía, porque es una lengua de neurocirugía.
Sí, totalmente.
Hello, Rashab. Did you fix your sound?
Yeah, can you hear me?
Yeah, I can hear you. Can you hear me?
Yes.
Okay, your picture is not working.
Yes.
Yes. Okay.
John.
Hey, how you doing, Dr. Parker?
Hi, John. How are you?
Good. How you been?
Yeah, good. Nice to see you.
You're working hard.
Yeah. Yes.
We got. I think we're shot.
Yeah.
I think you have two machines on. You have your smartphone and your laptop. You probably have. You got to turn off the sound of one of them. Either your laptop or your smartphone. I think it's coming from. Yeah. See. Yeah. Okay, I'm gonna make sure. See who's causing that.
Can you hear me now?
Yeah, but when you go
Okay.
on, you get interference. You need to fix that.
Yes.
You have two computer devices on, so you have to mute one. Okay, so mute one. Yeah, I'm gonna. Excuse me, Dr. Parthaban. We just have to get this straightened out here.
I'm okay.
Yeah. Okay, let me see here. Okay. Rolando, are you there? Rolando?
Yeah.
Yeah, I'd like you to meet Dr. Parthaban.
Yep.
This is he's a
Hello.
big spine surgeon in India. Rolando is a neurointerventionist from Argentina.
Hi. Hi, Ronald. Hi.
Hi, John.
Nice to see
I live
you.
in Buenos Aires.
Good to see
Yeah.
you.
You know, Dr. Parthaban,
you.
what Rolando does? He's pretty active on the internet doing live. He uses Instagram, and he has a community of strokes on stroke in Argentina. So he's building a community of live programs for patients. It's aimed at the patient. You know, the patient comes there and talks to the neurointerventionist, or he talks to Rolando, who does the show, and it's very interesting concept. More towards the patient. You know, we do doctor mostly stuff, but interesting stuff.
Sanchez, nice to meet you, Sanchez. Yeah.
Thank you.
Very nice
Thank
to
you.
meet you.
Oh, Ipe is here. My God.
Yeah.
All right. Didn't expect that. Hey, Ipe.
Welcome, Professor.
Hi, Rishabh.
Thank you, sir. Thank you for coming.
Guys,
Thank you for joining.
I'm actually to this to visit my son in Kerala. I'm actually on my weekend.
Yeah, the connection's not too good, Ipe.
I
How you
think,
doing?
I'm on the highway. I'm on the highway.
Yeah.
Okay. How you doing, Ipe?
Pretty good, John. Pretty good. I'm okay. So how's everybody?
Good. Dr. Parthaban's here.
Hi. Hi.
Hey, Party.
Hi. Hi.
Everybody,
Hi. Going on live. Yeah. I call you later. Yeah.
sure. You are lecturing, right?
Okay,
Yeah.
we're starting in 2 minutes, Rush. Okay.
Yeah. Presentations. Yeah.
Party, I will be logged in between. I don't know. Whenever I have the signal, I'll be logged in between. I'm
Yeah.
on the highway. I'm on the highway.
I understand. Yeah.
Yeah, whenever I get the signal, I'll be logged in. And once I'm in 1.5 hours, I'll be in Kochi. Guys are continuing, then I'll be there.
Sure.
Yeah,
we'll talk later too, Ipe. Okay.
Right.
Hey, Rush, I'll introduce you, okay, and you introduce yourself and what the does and stuff, okay, Rush? Okay.
Yeah.
Yeah, introduce.
Yeah.
And then,
We need just 2
and
minutes.
then
Yes,
after you explain what your organization is, then you
Yes.
can run the show. You basically introduce Dr. Parthaban, and you handle the question. You handle the after he finishes the questions, etc. Okay, and I'm just going to do background. I hope if you need, but you basically run the show.
Sure. Yes. Thank you very much.
Okay.
You just need a minute before my HOD logs in.
Yeah, 1 minute. Yeah. Okay, I got some people. You see all the people, Rolando? Puede deja entrar la persona, Rolando?
Yes.
Sí, deja entrar la persona tratando de entrar. We have a co-producer now, Dr. Parthaban. Like his job was letting the people in, you know.
Oh, good, good. Yeah, okay, that's great.
You know it, right? You know that's sometimes a problem with noise and stuff.
Yep. Yeah.
All right. Hi, Parthiban.
Hi.
Hi. Good to see
Hi.
you.
Hi. Hi. Hello. Hi.
Hi. Hi.
How are you?
All fine. Good to see you.
Yeah,
All right,
nice,
Rishabh.
nice.
We are ready to go.
Yes,
Yep.
I
Okay,
think we should
let
start.
me start in a second. Let me let a few more people in here. Last minute arrivals. Okay, we're ready to start. Okay, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning from Miami Beach. This is Dr. John Bennett for Neurosurgical TV. We have the honor of starting a new weekly webcast called the Neurosurgery Log, and I'll let Rashab Chetta, neurosurgical resident from the Mumbai area, explain the concept and run the show. Okay, welcome, Rashab.
Yeah, thank you, Professor John. Welcome to one and all. This is going to be one interesting event wherein we are trying to we'll be trying to run the show for all the neurosurgery residents. We are trying to have a small presentation, a case presentation in an exam atmosphere, so as to the residents interact with the lecturers and the professors, examiners, and the examiners. So without taking a lot of time, I think I'll just introduce our chairpersons today. I just need to share my screen.
Whoop, try again.
I'm not able to share my screen out here.
Well, give it a try. Give it a try. There's no hurry.
Okay, so I'll just be introducing my professors today. So today we have Professor Dr. Alok Sharma. He's currently the head of the department, professor and head of the department at Lokmanya Tilak Medical College in Mumbai. He's a director of Neurogen Brain and Spine Institute in Chembur and an honorary consultant in the Fortis Hospital. He's trained in Seth GS Medical College in neurosurgery and later on went on to take international fellowships at Stockholm, Denver in USA, as well as Karolinska Institute. He is one of the founding members of founding presidents to Stem Cell Society in India. He has been conferred with numerous awards and honors during his career. Including the Sushrut Award and Award. He's one of the pioneers in the stem cell therapy, especially for incurable neurological disorders. His interests lie in neuroendoscopy, psychosurgery, neurotrauma, spinal reconstruction, revascularization for cerebral ischemias. He has multiple publications, international and national presentations. If I'm not wrong, somewhere around 200 publications and 200 presentations. A very charming personality and an effective administrator. Can Sir just say a hi to the audience?
Hello, everybody. It's a pleasure to be here, and thank you, Rishabh. I think this is a great initiative. Where residents can directly, communicate with professors, and this will help them in the exams, because one of the things I find is when students come to the exam, they get very nervous. I mean, very, very simple fundamental questions they can't answer. And I think through this medium, they will have a comfort level with the professor. So when they actually come to the exams, they're going to be more relaxed. Of course, they'll be learning. There's interactive, and it's learning both ways. We actually learn more from residents at times than you learn from us. You learn from our wisdom and experience, but you guys have new ideas. So I think this is going to be a win-win situation for both. And thank you very much for arranging this. This is wonderful. I'm sure this will be a big success. Yeah.
Thank you, sir. Thank you for those kind words. The second faculty on the chair today is Professor Dr. Parthiban. He's a senior consultant neurosurgeon from Kovai Medical Center in Tamil Nadu. He's a post director in the DNB centers. He has been awarded the Team Tech Anesthesia Award of Excellence in 2004 and a leading spine surgeon recognition from Professor H. Michael Mayer and synthesis at Indian Spine Vision 2007. He has been instrumental in foundation of two major neurological associations in South India that includes Tamil Nadu Association of Neurological Surgeons and Coimbatore Association of Neurological Surgeons. Dr. Parthiban has developed double hook retractors for microlumbar discectomy and has newer concepts in adjacent corticocancellous bone grafts in anterior cervical discectomy and fusion, and is in the verge of introducing newer designs for cervical interbody cages. One of the founder members of NSSA, that is Neurospinal Surgeon Association, a teaching faculty for spinal surgery and in India and abroad, editor-in-chief of Journal of Spinal Surgery, official journal of NSSA. I do value for joining in the initiative, sir.
Yeah.
Can I have a comment from Parthiban, sir?
Yes. Yeah, Rishabh, it's a very good initiative, and I have to say all the best to you and also to the residents of not only from India, from abroad also. As Alok was mentioning, it's a very nice forum to discuss at an exam setting, which many associations are doing. But then the newer generations, that is, the initiation has come from the student side, so it is always a welcome issue. And I'm certainly sure that this will become a great success. And I wish you all the best. And I welcome all the students to this forum. Thank you. Thank you very much.
Thank you, sir. One last word, and thanks a lot for supporting me in all these ideas, to all the professors, including my HOD involved in the webinar right now. Special thanks to Dr. Aip, who has been really supportive regarding the program. And I thank him for joining me even today. Thank you, sir. Can we have a comment from Professor Aip?
Rishabh, anything for sharing the information? I know it was the spine session, and spine is not really my forte, but it's my good friend Parthi who is talking. And so that is why I thought I was on the highway, but I would wanted to join in, at least for a brief time. So all the best to you, and I hope that this gets to newer heights. And I am looking forward for more sessions from this. Thank you very much.
Thanks a lot, sir. And I senior faculties who have joined presentation. Neurosurgical resident from AIIMS Jodhpur. He's a good friend of mine. I have met him briefly in 2017 during our preparations. I'll introduce Dr. Tarunesh Sharma, presenting a case on cervical myelopathy. So a basic outlook for the case would be, the presenter would be presenting a brief history, including the examination for the case. He'll be giving a provisional diagnosis for the case. The examiners, that is Professor Sharma and Professor Parthiban, would be cross-questioning the resident. Later on, after that initial session of cross-questioning, we'll move on to radiological diagnosis and approaches for that particular case, the surgical approaches for that particular case. So I hand over the mic to Dr. Tarunesh Sharma. The stage is all yours. I hope you rock the case presentation today. Thank you. Tarunesh?
Hi, I can.
You can share your screen. You have a PPT ready.
Tarunesh, we'd like to see you actually. I mean, this needs to be visual.
Sir, my video is having some issues. Video is on, but it is not working well.
Because it works better if we see you actually. Yeah.
Yes, I also wanted to do that, but somehow not working well.
Your screen share is not working?
I'll share the screen. Sir.
Okay. There you go.
So good afternoon, everyone. I'm sorry that my screen is not working. Video is not working. I'll start the case directly. So my patient, he is a 6-year-old male, right-handed gentleman, uneducated, farmer by occupation, and a resident of Jalore, Rajasthan. History was given by self, and it was reliable. Trending complaints were weakness and tightness in both left and right, and weakness in and tightness in left lower limb for around 10 days. So he had weakness and tightness in both upper limbs for 1 month, which was insidious in onset and gradually progressive. First, he noticed in the left upper limb and the right upper limb. He was apparently asymptomatic 1 month back. He had he had difficulty in holding mug of water, then falling off objects from both hands. He had difficulty in buttoning, unbuttoning, breaking chapatis, and mixing of food. And then weakness gradually progressed proximally when he had difficulty in lifting the upper limb above shoulder for last 15 days and difficulty in pouring water over head while taking bath. He also had difficulty in taking food to mouth for 10 days and had difficulty negotiating both upper limbs while wearing a shirt for around 5 days. So he needed help for this of the relatives for this. Weakness and tightness of left lower limb for 10 days. Now, it was insidious in onset, gradually progressive, and first noticed that he had difficulty in negotiating left foot in and out of the slippers and could do that only after taking support of wall, and had slippage of footwear, which he had no knowledge of. Noticed that he has to drag his feet while walking and had difficulty in clearing the ground and walking for around 6 days, and was not able to lift his foot above ground and suffered twisting at ankle joint while walking on uneven surfaces. Left lower limb used to feel heavy, feel like a log and stiff, and the weakness gradually progressed proximally, and he had difficulty in getting up from squatting position, and he needed support to get up from sitting or squatting position for last 4 days. He had difficulty in climbing stairs, which he was not able to do now, and had difficulty in wearing trousers and had to wear trousers with support. But from last 3 to 4 days, that was done by his relatives. He feels unstable when and has tendency to fall in dark, and also had his feeling of falling down while washing face and while closing his eyes and washing face. There was no history of swaying while walking or difficulty in walking in narrow paths previously, but now he was not able to walk for the last properly. He did not complain any weakness in right lower limb, but he had difficulty in wearing trousers with both lower limbs, and he is able to take turn in bed with difficulty now, and needs support to get up from supine position in bed for around 4 days. He has no history of difficulty in neck holding or raising head from pillow. History of heavy weight lifting can be there, as it was occupational. He was a farmer and used to lift heavy weight. There was no history of any pulling sensation on back of thigh or no bend-like sensation over chest or abdomen. There was no history of any involuntary spasm of limbs or sudden jerky movements or abnormal movements of any limb. There was no history of any neck pain or no history of any neck click sounds or neck movement or neck tilt. He can feel his clothes over his body and can appreciate the hot and cold sensations all over his body. And there are no history of any painless cuts or burns, no history of any electric shock sensation with neck movements, no history of any loss of sensation in any limb, there is no history of decreased sweating on one side of the face, no history of recent trauma, no history of thinning of fasciculations in the limbs, and no history of cotton wool-like sensations also while walking. He had no history of any respiratory distress or breathing difficulty, and bladder sensations were present, and no history of any bladder involvement like incontinence or retention or any hesitancy. There was no bowel complaints like constipation or incontinence, no history of any recent cough or fever or weight loss, and no waxing or waning symptoms. There's also no history of any neurocutaneous markers. There was no history which would suggest any involvement of the cranial nerves or any lobar signs, lobar involvement, like he had no headache, no vomiting, no transient visual aspirations, no memory disturbance, no behavioral changes, no history of seizures or loss of consciousness, no history of any loss of smell or visual complaints or deviation of face or spatial sensory loss, no history of any regurgitation or choking sensation while coughing while due to choking sensation, no history of difficulty to rotate neck and is able to shrug shoulders, and no history of any difficulty in articulation of speech. At present, the patient is lying in bed and can get up with support and walks with difficulty and requires support while sitting, squatting, or walking. And so he needs help of his relatives for most of his daily activity. With the past history, he had bilateral knee pain for 4 years, for which he took occasional analgesics, and had a history of fall from height 10 years ago, after which he had tried clavicle fracture, but no neurological deficit was there, according to the patient. And no history of any comorbidities or any surgery. And family history, no, not significant. And person also vegetarian and had no addictions. So, shall I summarize?
Yeah, okay. Summarize. Now, what I want you to do.
Yes, sir.
And okay,
I
what I want you to, okay, first summarize, and then what I want you to do is I want you to correlate the symptoms anatomically and etiologically. All right, so first summarize. We listen to you. Yeah.
Okay, sir. So this is a 65-year-old gentleman who presented with asymmetric, gradually progressive spastic weakness of bilateral upper limbs and left lower limb, which was distal to proximal, with involvement of position sense. There was no other sensory involvement, no bladder bowel involvement, and no cerebral or cranial nerve involvement. So structures involved would be, sir, there will be corticospinal tracts bilaterally, and the involvement of dorsal column.
All right.
Continue with anatomical.
So anatomical localization would be above C5 and below foramen magnum, and horizontally it would be starting from left side, probably intradural extramedullary lesion.
Now, what makes you say above C5?
Sir, he's having weakness of upper limb. The upper limit of weakness is shoulder, and he's having no neck weakness and no respiratory involvement. So probably it will be because the shoulder is weak, the C5 must be involved, so it must be above C5 and below foramen magnum because there are no cranial nerve involvement. He is also not having any respiratory involvement, so C4 should not be involved. So we can also decrease it down to C5 level, but I've kept it like.
No, that statement looks to be very not correlating, Tarun. When you say above C5 and you said respiration is not involved.
Sir, weakness.
Yeah, diaphragm is not involved. But then you said there is a, he had difficulty in lifting the arm or lifting the hand. But at the same time, you also said that he had difficulty in, in chapatis, he had some problems, and he had difficulties in buttoning.
Yes,
so,
sir.
So what is the root value for those things? What do you want to say about above? Why can't it be below?
Sir, the hand muscles are usually C8, T1. The biceps would be C5, and shoulder is also deltoid and also supplied by C5. So according to me, the weakness is at the level of the shoulder. So above the level of from the level of shoulder. That is why I have kept it above C5.
So you mean that the whatever he had, that buttoning is all UMN sign or LMN sign?
Sir, that is UMN sign, sir. So because he's also having stiffness according to him, and weakness, both stiffness and weakness are there, which would suggest that upper UMN sign is there of the hand muscles.
Alok, you want to?
Okay. Why? So you say intradural extramedullary?
Yes, sir.
What makes you say that?
Sir,
What makes
it
you
is
say intradural? No, you specified intradural extramedullary.
Sir, it is asymmetrical.
Yeah.
First of all, then asymmetrical. It is not having any bladder bowel involvement, which is related in intradural extramedullary. There is no dissociative sensory loss, and while if in intramedullary it should have had bladder bowel involvement first, and dissociative sensory loss must have been there.
Okay, so we'll get on, because once you finish your examination, we'll have a better discussion. All right, maybe you'll get more insight. So continue. Yeah.
So according to me, there is a compressive myelopathy at the level of C5. Can be an intradural extramedullary mass, or can be extradural compression by. So I'll come to examination. The patient is conscious and cooperative, comfortable, lying in supine position, having no tachypnea or dyspnea. He has no low hairline or no low set ears, moderately built and nourished, no neck tilt or any facial dysmorphism. He is having no pallor icterus, cyanosis, edema, and or clubbing, and so both feet and lower half of leg are not shiny, no loss of hair are there. So skin and hair appears normal. There are no neurocutaneous markers, and he's having normal vitals. BP is also almost same in both supine and sitting position, and respiratory rate is also regular, thoracoabdominal, 14 per minute. On central nervous system examination, he's a right-handed person and conscious, alert, and language speech are normal. And cranial nerves, all cranial nerves were intact. Vision was finger counts at 6 feet was present. All extraocular muscles were normal, and trigeminal and sensory. There was no sensory involvement of the face. I mean, sensations of the face were normal, and lower cranial nerves were also normal, and there was no wasting or fasciculations of the tongue. Coming on to the motor examination part, the bulk, there was no wasting of fasciculations, and the size of and the bulk in all four limbs were almost same almost same bilaterally, and tone was increased in left side. It was grade 3 in left upper and left lower limb, and right upper limb it was 2+, and right lower limb it was 1. So all four limbs were spastic, more on left side than right side. Power, left power, if I come to shoulder joint, all the movements of the shoulder joint, right side were 5/5, but left side was 4/5. Elbow, right side flexion was 5/5 and extension was 4/5, while left side flexion was 4/5 and extension was 3/5. Wrist, right side flexion was 5/5 and extension was 3/5, and left side wrist was flexion extension both 3/5. Hand grip was not possible over the left side, and right side also it was very weak. Lower limb muscles, hip joint, all movements, left side were 4/5, right side was 5/5. Knee, flexion, left side 4/5, right side 4+/5, and extension left 4/5, right side 4+/5. Ankle joint, dorsiflexion and plantar flexion both were left side 4/5 and right side 4+/5. and EHL was left side 3/5 and right side 4+/5. Superficial reflexes, the abdominal reflexes were absent, the trimesteric anal bulbocavernous reflexes were absent, and the plantars were bilaterally upgoing. And the coming out deep tender reflexes, bilateral biceps left side were 2+ and right side was 1+. And left side supinator was 1+, and while right side was inverted. Triceps jerk left side was
Okay,
1+.
I'm going to have to, because normally in the actual exam, sometimes you're asked to demonstrate. So I'm going to ask you a few questions about the biceps. Now, just
Yes.
tell me describe to me how you did the biceps, because I find in exams, people fumble on these very simple things. What was the position? What was the position of the hand when you check the biceps? How do you keep it? Hanging loose? Was it flexed at the elbow? How did you check the biceps?
It will be flexed at the elbow. With me holding his arm above
Okay. Then
the elbow.
where do you keep you do it on your forefinger, right? You don't hit directly.
Yes, sir.
So where is your forefinger kept?
Sir, I usually
On what
do
anatomical structure?
so
I'm giving you a hint.
on the tendon, sir, biceps tendon.
Biceps tendon, yes. Now, when you do the biceps jerk, what action are you looking? What are you looking for? What movement is supposed to happen?
Sir, we look for the flexion of the. We look for the contraction of the biceps muscle.
And flexion of the
forearm.
Elbow, yeah, flexion of the elbow. So, what is
Yes.
the segmental innervation of this reflex?
So it's C5, C6.
C5, yeah. C5.
Yes.
And what nerve is involved over here? Which is the peripheral nerve involved?
So biceps.
These are very elementary things. Yeah, and this is where in the exams you get stuck.
Biceps is musculocutaneous.
It's the musculocutaneous. Yes, it's the musculocutaneous. All right. Next, you mentioned the supinator. So now tell me, how did you do the supinator? How was the hand placed? Where was the hand placed?
So it would be kept in mid-prone position, and flexed at the elbow joint.
And what do you, so like for the biceps, the anatomical structure you hit is the biceps tendon. For
So
supinator, what do you hit?
styloid process. We'll tap on the styloid process of the radius.
At the lower end of the radius, yeah. About how much from the okay. Now what contraction are you looking at? Which muscle contracts?
So brachioradialis muscle.
And what movement do you look for?
So we look for supination from the mid-prone position.
What do you look? What happens when you do the supinator? What happens?
So there is contraction.
Sir, because the next question will be what's inverted. What is inverted? Because you mentioned inverted, so I'm going to come to that.
Yes, sir. Yes,
okay,
sir.
so what in a supinator jerk normally what would you see, and in inverted what would you see?
So supinator, we will usually see that the hand there is supination of the.
No, see, keep it simple. What is the movement that you look for? What muscle contracts? It's very simple. It's not complicated at all.
Brachioradialis muscle would contract, and we'll see for contract.
What is the movement? What is the movement you look for?
So we look movement at the elbow joints from at the forearm that turns into
flexion of the elbow. That's right. Yeah. Yes. What else can happen? What happens to the fingers sometimes?
The fingers contracts that.
What do you mean contracts? What is the meaning of contracts?
So fingers, the thumb and
no, the legs extend. What is the meaning of contract?
So
a muscle. Try to understand. A muscle contracts. Okay.
Yes, sir.
And an anatomical. So the elbow, the fingers, they move. You see, contractions of a muscle. So you can't say fingers.
Yes,
have you understood? See, get this very clear. There's a muscle that contracts and a movement happens. There is a nerve that has a segmental innervation. I mean, it has a segmental innervation. There's a nerve. It's all very simple. All right.
Yes, sir.
So what is the segmental innervation here, by the way?
So C6, C7. Sorry, C5, C6. Brachioradialis would be C5, C6.
By the and what is the nerve? What is the nerve?
Radial nerve.
Which one?
Radial nerve, sir.
Radial. That's right. Now you mentioned that your right is inverted. So how is the inverted supinator different from a regular supinator?
Sir, the movements of the fingers, the flexion movements of the fingers are normally not seen. They are seen when the jerk is inverted supinator reflex is there.
Say it again. You're not making it clear. That's why I first asked you what is a regular supinator. So what is the inverted? How is the inverted supinator different?
Sir, there is no
What
flexion in
response will
that.
you see in a inverted? What is the thing that you will see? The fingers, or I'm hinting to you.
Yes, sir, the fingers will come in
What is
come close.
absent and what is present?
Sir, elbow flexion is
Flexion is
absent and
yeah.
elbow
No,
flexion
you're
is
right. You're
absent.
right.
Yes,
Yeah.
sir, elbow flexion is absent and there is contraction of the fingers, usually the middle and the finger and the thumb.
So there is when finger flexion is the response, and when contraction of say the brachiolitis elbow flexion is absent, then it is said to be inverted. Now,
Inverted, yes.
if you have an inverted reflex, what is likely to be the biceps and what is likely to be the triceps?
Sir,
If you have an
triceps,
inverted
yes, sir.
supinator, is what is likely to happen to the biceps?
Sir,
Are you
biceps
going to be absent exactly
must
at
be
what? I'm hinting. I'm
diminished.
giving you hints while I'm
Yes,
asking
sir.
you.
Biceps must be diminished and
Yes,
triceps
it'll
will
be
be
absent. Triceps will be
exaggerated, sir.
exactly okay. You know it. It's just not coming out. There's a
Yes,
reason why I'm doing this, because I find in exams it is over these things that people get stuck and confused. So I just want to simplify it. All right,
yes,
go
sir.
ahead. So now you mentioned triceps 2 plus and 1 plus. So again, I'm going to ask you the same questions. Tell me
Yes, sir.
first how you did the triceps. What was the position of the hand?
So position of the hand was in flexion and in flexion, and I hold the arm and then
No,
tap
this
at
is
the.
not confusing. This is very simple. I mean, I'm
Yes,
just
sir.
asking you how. You take it. What do you flex? Where is it kept? Do you keep it? Do you keep the arm over the abdomen?
Yes, sir. We keep the arm of the abdomen and then.
Yeah, so it's much easier, no? Because you keep it over the
Yes, sir.
abdomen, then across the
And
trunk, you let
then
it lie loosely. Now, what is
yes,
the anatomical structure you strike when you do, like for biceps, we said we hit the biceps, this thing. So now
yes, sir.
here, the biceps tendon. So for triceps jerk, what do you hit? What is the anatomical
So,
structure you hit?
so olecranon,
No, no.
the triceps tendon.
Triceps tendon, exactly. Triceps tendon. And where exactly do you do it? How much above the elbow?
Uh, Sir, not exactly in centimeters, just above the elbow, sir, where the
Oh, 3
insertion is.
inches. Okay, fine. Yeah, just now, when you do a triceps, what are you looking for? What is a normal triceps response?
So the contraction of the triceps
No,
muscle
no,
will,
yeah. So
and
no, so no. You see again clearly. What is the movement you look for? What is the contractions? Remember the difference. A movement is a flexion or extension.
yes, sir.
Contraction is of a muscle. All right. Contraction is visible. Movement. You see it in the muscle and movement. So, what movement will you see at the elbow? Will you see an extension or a flexion or a what? I'm
Sir,
hinting your
extension.
answers while
Sir,
I'm asking
yes,
you.
sir. Yes, sir. We'll see an extension of the elbow and
Extension of the elbow, exactly. What contraction will you see?
so triceps muscle contraction will be there.
Okay. And what will be the segmental innervation?
We see 6, 7, and 8.
Yeah, okay, that's fine. 6, 7. And which nerve what is the peripheral
Radial,
nerve?
radial nerve.
Yes, okay, that's good. All right. So now you go ahead. So now okay, so have you understood? I'm just trying to, get your
Yes, sir.
thoughts in place, so that
Yes, sir.
when you look at when there's a reflex, you know exactly what's going on. What are you how you do it? What are you looking for? What is the segmental innervation? What is the nerve supply? So this should be clear because this will help you to correlate. All right.
Yes, sir.
And now you so okay. What else? So that's the upper limb. What about the come to the lower limbs now?
Lower limb bilateral knee jerks were exaggerated, with 3 plus, and ankle were also 3 plus, and Hoffman's while doing the upper
Okay, now tell
limb.
me how you did the knee jerks. How did you do it? Just tell me the
Uh,
position. I mean, let's say the patient is lying on a bed, and you said, and then what do you do?
Sir,
How do you
we
hold? Do you just keep it there? What is the position of your hand?
so
Where are you
we
standing?
we hold the leg on our arm.
Yeah. You do one or you both?
Sir, we do it one by one, and while
What is
doing
the
it on the
advantage
same,
of having both?
so we can compare.
Exactly, we can compare. All right. All right, then go ahead. So then what do you do? Now, what is the anatomical structure that you hit with your hammer?
So the patellar
Tendon. That's right.
tendon.
Very good. The patellar tendon. Yeah.
Yes,
And
sir.
so what, now again, remember my question. What is the movement you look for? What is the muscle contraction you look for? The movement is
So,
of what? What movement you get when you hit it?
so we look for the extension of the knee joint.
Extension of the knee. Exactly. Extension of the knee joint. And what muscle will contract?
Quadriceps femoris will contract, sir.
Quadrant. All right. And the segmental innervation?
So L3, L4.
All right. And what nerve is involved here?
Uh, femoral.
Okay, that's
Femoral.
good. That's good. All right. And last, I won't trouble you too much because we've done enough of it. I just wanted, all the students to understand. The last jerk, I'm not going to talk to you after this. I'll hand over to Dr. Parth. You want to tell me, okay, the ankle jerk. You said ankle is 3-3. First, tell me, what do you mean by 3?
Three.
Ankle jerk.
So it was exaggerated. Was more than the normal jerk.
What is the implication of that?
So
When both the knees are 3 and ankles are 3, what is the implication?
So the bilateral lower limbs are having upper motor neuron type of lesion, and then
Okay, fine. All right. So roughly the ankle now. How can you just describe what is the position of the leg when you did the ankle jerk? How did you do it?
Sir, I flexed the knee joint and kept the.
What about the leg? Do you do anything to the leg? Is the leg straight? Do you
So I kept the leg
externally rotate
with
it?
the other leg to.
No, do
So
you
that
externally rotate it? Do you internally rotate it? Do you keep it neutral?
we rotate it internally and
All right.
keep it
Do you
over
flex the knee? Do you keep the knee extended? How do you keep it?
So we flex the knee and in abduction and kept the foot over the other opposite lower limb and
And what do you do to the foot? Is the foot in a neutral position? Is it plantar flexed, dorsiflexed? When you check the ankle.
yes, sir. So it's dorsiflex.
Yeah, you're right. You're right. Yeah, you're right. And how do you dorsiflex it? I mean, what do you do? Do you ask the
So we
patient to do it, or do you do it?
So we do it by ourselves passively, not ask the patient.
What anatomical structure do you hit for this reflex?
So the gastrocnemius tendon at the ankle joint.
There's some weakness. There's a weakness called it. There's something called Achilles. Have you heard of? Okay, that's fine. Yeah. All right. Now, what is again the same question? What is the movement you look at? What is the contraction you look at?
Contraction of the gastrocnemius muscle
Yeah.
and
the foot plantar flex or dorsiflexes?
plantar flexion.
All right. Segmental innervation?
S1.
And which nerve is involved here?
Tibial and posterior tibial.
Not tibial.
Sorry, peroneal.
Medial popliteal. Okay, fine. Now go ahead. Now I did this intentionally for all the students because I just wanted you to know that our experience in exams is people get stuck on these very simple things. So I know this is boring stuff, but I just wanted to emphasize something. Okay, now I'm not going to interrupt. Now you go ahead. Now you okay? Mention Hoffman. Tell me about Hoffman. How do you do Hoffman?
Sir, we hold the middle finger.
Middle finger, yeah.
Middle finger in.
The middle finger is held between what and what of yours? How do you hold it?
Sir, between our thumb and finger, we hold that at the proximal interphalangeal joint.
And then what do you do?
We flex the nail and then leave it. We do at the nail. We cut the nail and leave it suddenly so that if there is contraction of the thumb and there's flexion of the thumb and finger coming towards each other, then the Hoffman sign is positive.
All right, go ahead with the rest of the examination. Go ahead. Yeah.
Yes.
Now I won't disturb you for the rest. Now you finish. Yeah.
So there are no involuntary movements seen. Sensory, touch, temperature, pain were normal, but vibration sense was impaired below the shoulder joint over the left side and also in the left lower limb. Bilateral lower limb vibration sense was impaired, and joint position sense was also impaired in left upper limbs and bilateral lower limbs. Rhombic sign was positive, and other perineal sensation and tactile localization was normal. There were no cerebellar signs or any lobar signs or meningeal
Just go
signs.
back to the sensation 1 minute. I just go back to the sensation. Okay, just all right. Okay, all right. Go ahead. Yeah.
Sir, tandem cerebellar signs were not present. Some of them I could not do because of spasticity and weakness, but there was no and gait. He had to walk with support and had scissoring gait and had to drag his left feet. Um, the otherwise spine, there was normal curvature, no tenderness, and coming on to chest examination, expansion was 2.5 centimeters. Single breath count, he was able to do it up to 11, and breath holding time was around 16 seconds. On tidal percussion, there was a shift of 1 intercostal space. There were no added signs. The cardiovascular system and abdomen were normal. The bladder was not palpable. There was no hepatosplenomegaly, no ascites. Sir, stop.
All right. Go ahead. Yeah. All right.
Summaries.
First,
Yes, sir.
first tell me now. Whatever you told us in your history, does
Yes, sir.
your physical examination collaborate that, or is there a difference?
So there is an addition of spasticity and weakness in the right lower limb also,
Okay.
which was
All
not
right. Go
in
ahead.
the.
Right. Okay. Go ahead with your summary. Yeah.
So, sir, 65-year-old gentleman with gradually progressive, asymmetric, distal to proximal, spastic weakness of all four limbs with involvement of position sense. That is posterior column. There's no other sensory involvement, no bladder bowel involvement, and no cerebral or cranial nerve involvement.
So you're all right.
So, cell structures involved would be the same as the corticospinal tract, left more than right bilaterally, and the dorsal column. And the anatomical localization will also be the same, sir.
All right. So what's your differential diagnosis now? Yeah.
Sir, probably if that's a compressive myelopathy of intradural extramedullary, then it would be an IDM. More chances of having a meningioma than a schwannoma.
Why do you say that?
Because he is not having any root pain or any neurocutaneous markers to suggest for schwannoma. So meningioma have more chance of IDM. And after that, if that is not there, then extradural compression can be there, which other causes I will keep as because of the age, degenerative cervical spondylosis and OPLN.
All
Tarun,
right. Sorry. Go ahead, Parthivan. Yeah.
yeah, I'm just having a, I'm trying to ask you one simple thing. Why these tumors are coming as your first line? Why the degeneration is not coming as first line? Do you have any specification for that?
Sir,
And
because
if you let me finish, you see, because
yes,
if I go through your history, I told you that time itself, it's not above C5. It may be C5 or below, or somewhere in that region. But if you carefully look at that, your weakness is more on the left side, and your the jerks are slightly are changing towards right side more, and there is an inversion is there. Don't you see the disparity which is happening at that region? This
yes, sir.
kind of disparities in which condition is more common? Is it in the tumors or in the degenerative spine?
So degenerative spine, they are more common, sir.
Then why did you put ID? Because because you have been, projecting as if that you're presenting an IDEM, but it turned out to be a degenerative. But your history is already giving lot of information. And
Yes,
also,
sir.
I would like to know what you learned from the timing of the disorder. The whole timing of the disorder. How much is about a month or before that?
Yes, sir, it's about a month.
Right. So that is did that made you to think about these tumors?
Yes, sir, that is also corroborating that, and also he was not having any neck pain or any root pain to suggest uh, history of any degenerative disorder. That is why I
Basic,
kept it.
basically, in the history, what kind of job he was doing, though he was uneducated? He's
So he was a
pharmacist.
farmer and he had history of heavyweight lifting,
Yeah.
but he didn't complain of any neck pain before.
No need to be. Okay. Anyway, so this is what my interesting points which I wanted to make, because most of the thing you got it in your history. In fact, if I'm very correct in that, because most of the points you made in the history are excellent, but only thing is interpreting the history is much important, because
Yes, sir.
many times students like Professor Alok was asking you so many questions on this jerks, because the importance of the jerk is not only for diagnosis. Believe me, please understand it. It comes follow. We will take you through the next discussion about it. So why it is very important, and what makes it more special. As a surgeon, you wanted to see the jerk, the reflexes, because the students are not taking much interest in all those things, right? And unless you know the how to make the jerk, and unless you know what is the intensity of the jerk, the grading of the jerk, you cannot understand about your preoperative or postoperative results. Now, having said that, and then hope you understand that the IDEM which you made is the first line of your diagnosis. Would you like to change it, or would you like to still keep it as IDEM as the first line of your thinking?
Because, sir, it's the extradural compression is not explained by
You still like to keep as
yes,
IDEM as the first line of treatment,
yes, sir,
the first line of your diagnosis? Yeah.
yes, sir.
Now, can you tell me that in how many IDEMs that you have the posterior column quite often involved
Sir,
when compared to your corticospinal tract? How many patients you have seen? Of I just want is a very important point, because you said that the posterior column is involved. Am I correct?
yes, sir,
Now you plan now what is the pathophysiology which you're thinking about.
yes,
You
sir,
need the corticospinal tract to be compressed or distorted. At the same time, there should be some compression over the posterior column.
yes, sir.
So what kind of meningioma? You feel the meningioma all around the spinal cord or the
No, sir.
schwannoma? Am I correct?
No, not all around.
Are you able to think what I'm trying
Yes,
to talk?
yes, sir. I'm
You
understanding.
understand?
Yes, sir.
See, in a spinal cord, for example, a spinal cord tumor is pushing from the left side. You start getting the problems from the left side,
Yes, sir.
right? Left
Yes,
side,
sir.
and then progress,
Yes,
right?
sir.
But in this case, if you carefully watch, your symptoms and signs which you have described is more not only corticospinal tract, but also posterior column. When they are
Yes,
coming together so fast and quick, I generally feel that I'm not very sure about it. Can put it as IDEM first. Okay.
yes, sir. Yes, sir.
Yeah, I think you have to rethink about it. And okay, I think Alok.
Yeah, fine. I sort of agree. But let's go ahead with the investigation. You have okay. So, Tarunesh, this patient comes to your clinic now. Okay, you are
Yes,
practicing neurosurgeon,
okay.
and he tells you, doc, doc, what is the problem with me? And so, what are you going to tell him now? What is next for you?
So I would like to investigate the cervical spine.
Yeah.
Uh,
What will you
would
do?
do
You will do an MRI straight, right?
yes,
I mean, do
MRI scan.
you have an MRI with you?
Yes, sir.
Yeah. Let's see it.
Just So here's a T2 weighted sagittal MRI showing compression of the spinal of the thecal sac, and from the level of C2, C3 up to C6, C7, the multiple levels, and there are there is hypointensity the posterior longitudinal ligament area, so maybe that is hypertrophied, and also there is ligamentum flavum hypertrophy, that hypointensity showing ligamentum flavum hypertrophy. And coming on to axial sections.
So Dr. Parthiban was right, huh?
Yes, sir.
Okay. Yeah, go ahead. Describe this. This is more important. Yeah.
This is an axial. These are axial sections. MRI of C2, C3 level, which show that the thecal sac is compressed, and there is hypertrophy of the posterior longitudinal ligament, which is compressing the cord. Also, there is hypertrophy of the ligamentum flavum, and there is these are again axial sections which there is maximum compression here in these are at the level of C5, C6 over the right side, and then C6, C7 are also having compression. These are T1 images again of the same levels, and shall I come to CT scans or?
Yeah.
Yeah. Okay. Now tell me, as a you're a neurosurgeon, so you're going to be operating this. So how when you're looking at these images, what is your mind thinking?
Sir,
as a neurosurgeon, okay, forget how radiologists see this. Okay, you're a neurosurgeon.
yes,
When you see this image,
yes.
what's your mind thinking?
So there is a compression of the cord, and there are also cord signal changes. So
No, I specifically said as a neurosurgeon, which
yes, sir.
means I'm assuming you want to operate. So how does your
Yes.
neurosurgical mind work?
Sir, I would like to
So what are the
decompress.
questions you have to ask? I mean, first, of course, in your mind is, will this require, will this require surgery or not? Okay, for that
Yes,
you
sir.
need to know, is there compression, is there instability? Then you need to see whether it's anterior, whether it's posterior. You need to see all that, right? You have to decide your approach.
Yes,
So I want you to talk like that. Talk like a
yes, sir.
neurosurgeon now. Yeah.
So we would. So I would like to uh, have like to know whether there is any instability of the spine,
No,
and
forget instability. I just mentioned that. I mean, this here instability is not the important criteria.
yes, sir.
Compression.
Compression. Yes, sir.
Where is the compression? Is it anterior? Is it posterior? Is it both? How severe it is? What is it doing to the cord? All of that. I mean, because when you go
Yes, sir.
inside, you have to decide what to go, right?
Compression is present on both sides,
Yeah.
anteriorly and posteriorly, and it is compressing the cord. And there is the canal
And
is
at what levels? See, there are multiple. I'll
multiple
just give
levels.
you a hint. I want you to tell me everything.
Sir, at the level of C2, C3, and C3, C4, there is
Yeah.
maximum compression.
Hmm.
The canal is tenosed most at this level, and also there is compression at the level of C5, C6. After that, more at C5, C6, and
What is that
in
compression
levels
caused
also.
due to? Was it is it the disc? Is it the osteophytes? Is it the PLL? What is it? What is it that is causing that?
Sir, he is having at the level of C2, C3, C4, there is ossification of the posterior longitudinal ligament, and posteriorly it is the ligamentum flavum hypertrophy, and he's also having osteophytes. All of this causing compression of the cord.
All right. Now, what is happening to the cervical, the cord itself?
Cord
What
is,
are the
sir,
changes in the cord at different levels?
sir, there are the CSF signals are absent at the level of C2, C3, C3, C4, and up to C7, and there are also cord signal changes in at the level of C C6, and
Yeah.
the cord is stenosed. The canal is stenosed maximum at the level of C2, C3, and C3, C4.
All right. Parthivan, you want to?
Yeah, I like. But what are the other scans you have done in this further to MR?
CT scan was done, sir.
Can you show me the CT scan? Okay. Now, can you explain what type of problem you are dealing with now?
Sir, we are dealing with ossified posterior longitudinal ligament and with
Up to
ligament.
what level? OPLL up to what level?
Sir, that's mixed OPLS. In this picture, we can see that it is from C2 to C4.
Yeah.
It is present, and in other slides, it is also present below. So it's a type of mixed OPLN.
You have some more CT scans?
Sir, I have slides
Okay.
of different C4s, then a C5, and also at the level of C6, C7. It is present.
Okay. You have anything else you have done? The basic X-rays?
Sir, that was done outside. I have not taken photographs of that.
No. What was the what kind of X-rays was there that time?
Sir, cervical spine, EP and lateral view, and lateral flexion extension.
So what did you notice in that?
Sir, that was done to initially to start with the diagnosis and also to rule out any instability.
So what was there actually? That's what more
Sir,
interesting.
so the X-rays showed that there were osteophytes at multiple levels, and there was decreased lordosis of the cervical spine.
Was there an instability over there?
No instability, sir.
So it was more rigid, or in
Yes, sir.
was there
Yes,
loss of lordosis on flexion?
Yes, sir. There was loss of lordosis.
So in that case, which level it was more significant?
Sir, in X-rays.
Yes, and X-rays only I'm talking about. X-ray is very important.
Yes, sir.
No exam goes without taking X-ray. The dynamic X-rays, and no postgraduate should present without an X-ray. I'm very particular because now you have shown MR and you have shown the CT scan. It's very clear. On the upper cervical region, you have an anterior compression and also posterior compression. It's more pincer. In the lower cervical, you have more of the posterior. That's your ligamentum flavum is buckling and you have more compression at the lower level, right?
Yes, sir.
Now there is a segmental difference. If you see the CT scans sagittal view 2, 3, 4, 5. Did you notice 4, 5? There is an anterior osteophytes.
Yes, sir.
And would you? Because I would like to see what's happening in this region on flexion. Now, why it is important?
Sir, because if we plan for surgery, then stability would be the deciding factor whether to go anterior or posterior.
Yeah, good. So whether to go to anterior, posterior, or to stabilize or not to stabilize. Okay.
Yes, exactly.
Right. So what's your plan then?
Sir, my plan would be to...
I ask you, suppose this patient says he doesn't want surgery. Okay, patient says, I don't want operation. What will you tell the patient? What is likely to happen to him in the future if he doesn't get operated? What will you tell the patient? Patient says, I want surgery. What will you tell him now?
Sir,
what is the natural? In other words, I'm asking you, what is the natural history of this disease?
Sir, it will involve respiration also because of the level of the cord.
No, what will happen to the limbs?
Sir,
what will happen to the lower limbs, the upper limbs?
So the weakness will increase in all 4 limbs, and he'll be quadriplegic, and slowly the respiration will also involve.
Now, if you look at this patient and this over how long how long do you think this will happen? If the patient says, "Oh, how long will that happen?" What would you say?
Sir, the weakness has increased in last 1 month.
Exactly. Yeah.
So that he was not having.
Yeah.
So
Yeah.
it will,
Okay, so now, okay, so the patient says, yes, now we'll talk about surgery. So what now? Planning of surgery, all right? What kind of surgical approach will you plan? Now, when you talk about this, you have to talk about whether it's going to be anterior or posterior. You have to talk about the levels. You have to talk about decompression, stabilization. You have to talk about all these factors when you talk of surgery, all right?
sir, in this patient,
And you have to give reasons why, okay? For everything, you have to give reasons.
sir, because
And then Dr. Parthiban will come into the discussion. Yeah. But first, we want to hear from you. Yeah.
the compression is at multiple levels, more than 2 levels are involved. So I would like to do a posterior decompression, which is better. And in posterior decompression,
Arun, Charnes, can
yes,
you
sir.
go back to your MRI picture?
Yes, sir.
Have you put a K line?
Sir, I have not put in this.
No.
Yes,
What is K line?
sir, it's a line which is drawn from the posterior part of the C2 to the posterior part of C7.
So
Sorry,
you know what is K line, but why did you put in this case?
sir, in graphs I didn't.
No, you must, every case I tell you, every patient.
Sir, in a
every-
PPT, I have taken a photograph of that, but in this PPT, I have not.
But you know that, no? What is K line here? In this diagram, if you put a K line,
Yes, sir.
will it be on the positive or it will be negative?
Will be, sir, negative, sir.
No. What is, see, when you put a K line here, right?
Yes,
All your osteophytes which are in front will be in front of the line.
yes, sir.
That means it is positive, right?
Okay. Yes, sir.
So you have to mention about K line. Without mentioning K line,
Yes, sir.
OPLL has no close. Please understand.
Yes, sir.
You will never go beyond the discussions. Very important. Because why it is important?
So it helps in deciding whether to go for anterior decompression or posterior decompression.
Yeah. What it signifies? K line positive. What it signifies?
So then, if it is crossing, then
It
yes, sir.
signifies that there is a lordosis. Okay.
Yes. Yes.
And biomechanically, if you have a lordosis, you have lordosis. And if you do not have a lordosis, if the K line is negative, for example, the line crosses the osteophytes.
Yes, sir.
Okay, that is, or your OPLL. The line crosses the osteophyte. That means it has a tendency to become hyperkyphotic after your posterior surgery. So you may have to do anterior surgery.
Yes.
You get my point?
Yes,
So
sir.
K line you have to put in all patients. K line must be put. It must
Yes,
be methodical.
Yes, sir.
So that is why I asked you about the X-rays. So
Yes,
you
sir.
can put you can put your K line in X-ray. You can put your K line in MR sagittal view, mid sagittal view. You can put your K line in CT sagittal view midpoint. Those times you have to put K line, which is very important to make a decision. If the K line is positive, then you go posterior approach. Okay, I agree with you in posterior approach. Now you are going to do posterior approach. So from where to where you do that?
Sir, from the level of C2 to C7.
Yeah. So C2 to C7. So what else you would like to do? You do only the posterior. What surgery you want to do?
Sir, we can do we'll do laminoplasty.
Laminoplasty. Then?
And decompression by excision of the ligamentum flavum. And when the sac will be decompressed and open in laminoplasty.
So you like to prefer for a laminoplasty over laminectomy, or?
Sir, yes, sir, laminoplasty has shown better results. So laminoplasty should be
Okay,
done.
that's more of okay, right, fine. Now, as far as I'm concerned, I have only one thing that one important thing is that I'm not very convinced about the instability part
Yes.
because we don't have the X-rays. That's very important for this case. But I still feel that if you carefully look at C5 and C6, at C5 and C6, there's a small stepping over there. Are you able to see that?
Yes, sir.
Small stepping is there. So it is not looking great at C5 and C6 small step, and C6, C7 looks okay, but C5, C6. So you post laminectomy, you may produce instability.
Yes, sir.
So
Tarun, I say I disagree with you, and I think we should go anteriorly. How will you sort of argue, discuss with me? I feel that we should go anteriorly. There's too much compression anteriorly. Okay, before that, what are the chances of complications of posterior decompression? So you do a laminectomy, what could possibly go wrong?
In a laminectomy,
Or
posteriorly,
yeah.
sir, it can be while doing, we can injure the facet joint while that will create.
You're a good neurosurgeon. Yeah, why will you injure the facet joint? I'm
Okay.
talking of you do good surgery and you have a complication.
So then they
The
can be.
compression is anterior. You do a posterior decompression. What will happen to the cord? What movement happens to the
It
cord?
will be shifted posteriorly. So
what's it called?
posterior.
Bowstring. Yeah, we heard of bowstring.
Yes, sir. Posterior.
Yeah. So what happens if there is an injury? Where will the injury? What will happen to the cord? Because if you notice that your OPLL, you want to do C2 onwards, right?
Yes, sir.
But your OPLL extends up to where?
So it extends up to upper part of C2 only.
All right. And so when you do this, what is likely to happen to the cord, particularly, I'd say the lower levels, C3 below, whether even lower down. What will happen? The cord is going to move backwards, right?
Yes,
So what could happen? I'm not saying it'll happen. You're a good surgeon, but what could happen?
So dural injury can be there, and CSFT can have. And
you're a good neurosurgeon.
surgical
You will not
technique.
cause dural injury.
Yeah.
Why will you cause dural injury? You will not cause a CSFT and all that. I'm saying naturally.
So kyphosis is.
Okay, tell me what position will you operate in? What position?
Sir, prone position.
Sitting position, or have you seen this being done in sitting or no?
Yes, no, sir. Prone position with head fixed.
You prefer prone, fine, yeah. All right. So I'm telling you that I prefer going anteriorly. Now argue with me, why not?
Yeah.
Sir, anteriorly, first of all, there are multiple levels involved. More than 2 levels are involved. Anteriorly, we can. There'll be more.
You can't do 3 or 4 levels. You're a very, very good spinal surgeon. Huh? Why can't you do 3? If you can do 1 level, why can't you do 3 levels or 4? What are the other reasons? There's some other reasons why.
Arunesh,
yes, sir.
The Professor Alok is asking you to debate yourself in your mind.
Yes,
First,
sir.
you said it is posterior. Now you have to debate yourself. Now, why not anterior? So, what are the points that you feel that it is against for anterior? Those are the important points. Like, for example,
Yes.
how many levels? Decompression is a technical issue, right?
Yes, sir.
So you can always do the decompression, but how many level you decompress, and subsequent to decompression, what you may have to do.
Exactly.
Those things are possible. So you have to discuss that point.
Yes, sir.
Can you do that?
Sir, we'll have to do fixation, and if we are doing anterior decompression at so many levels, then we'll have to also put we have to fuse, and we can that will at so many levels this will cause injury to that may cause injury to the surrounding structures, and post-operatively there can be.
So what surrounding structures? No, don't talk loosely. Surrounding structures means what now?
So they can be
What are you
so
going to damage the esophagus, trachea, larynx, pharynx, carotid? What are you talking about? Spinal cord, nerves?
so post-operatively they can be
No, wait.
swallowing difficult.
No, 1 minute. First, we have to assume that you're a very good neurosurgeon, so there's no technical mishap. We're not talking about technical mishap. We're just talking about a good surgery, and you still, what Professor Parthiban said, we are not arguing. We are just in your head to get clear what to do.
Yes, sir.
So so you tell me, no, I don't think we should go anteriorly because of the following reasons.
Yeah, you said one is multi-level, yeah?
Multi-level.
Yes,
Okay, we accept that. Yeah.
Yes,
Next.
next,
Skip. You see that it is skip there. From C2 to C4 upper level, you have one
yes, sir.
OP error, right? So
Yes,
you may have to do a long C2 upper lower half, and then maybe C3 or C4, C5. So it's a kind of whether you do a corpectomy or you do a discectomy and OPLL at multiple levels, right? And then
yes, sir.
again come down. You may have to come down, but in the
Yes,
lower level, you have the pressure is more from posterior than when compared to the upper level, right? So these are the
So
different.
these are the points, exactly.
These are
So
the
this is what
different
I wanted
points.
you to tell me. Yeah.
okay.
This is very important point. That's what he was expecting it, because
Yeah.
and
Exactly.
C2, C3, C4, it is more an anterior. And when you come down suddenly, C5, C6, the compression is more from posterior. So put
Yes,
together, you are gifted with a K positive case, would you like to go posterior? So this is how you have to debate yourself and put it forward to the examiner.
yes, sir.
Now, my next question is, I would like to say, now, would you like to stabilize this patient or not stabilize the patient and leave it alone?
Sir, we should to stabilize.
It's very difficult to answer. You find it very difficult to answer. This is where your X-ray would have given you one important message, right? But there is always a steppings. When you see steps, they tend to collapse over a period of time. So it always prefer to stabilize. But if you
Yes,
like to stabilize, if in case you plan for stabilization, from where to where you do?
sir, we'll have to
What
stabilize.
is? I will ask you one more simple question. What is the significance of exercising all those muscles which are attached to C2 spinous process? What will happen there?
Sir, I didn't understand your question, sir. Can you?
C2 spinous process, how many muscles are attached there? Insertion. Okay, see, this is very important point you have to learn, okay?
Yes, sir.
You know the capital muscles, right?
Yes, sir.
6 muscles. So they are very important because they hold C2 in a precise way. And since you go posteriorly, you exercise them, you may get C2, C3 instability over a period of time, though the OPLL is there. The OPLL looks very strong, but they are not strong. And down, you have C5, C6 steps. So I would like to do a multi-level stabilization. Would you like to or no, would you not? Because the way you took, it looks like only for decompression. Am I correct?
Yes, sir.
But have you seen patients which lost the lordosis posterior post laminectomy?
Sir, I have not seen, but read about.
Yeah, correct. You will read about it in future. You know about it. So you should be very careful. But if you wanted to do stabilization, what are the techniques would you like to do?
So posterior stabilization.
What are the posterior stabilization techniques after decompression, a laminectomy?
Sir, we can. So I've not read those stabilizations.
You're not familiar with lateral mass fixation?
Like retromass, yes, sir. Retromass fixation.
Yeah,
Yes.
you have to tell lateral mass fixation. You have to talk about pedicle screw, pedicle
Pedicle.
fixation.
Yes, sir.
Yeah.
Yes, sir.
At C2,
Sir.
what kind of screws where you put? So you
Sir,
must be
no?
you must be thoroughness. You must prepare when you present. You must prepare so in depth, right?
Yes, sir.
And there are more to discuss on this particular subject, right?
Yes, yes, sir.
You didn't mention about. Okay, I don't want to go back because you never mentioned about Japanese Orthopedic Association modified
Yes,
MGOA score.
yes, sir. That was I've done that. I've not written it in.
No, you should. It's very important. Why? See, please understand. After your surgery, you have to assess your patient.
Yes, sir.
You have to follow up your patient.
10 in
You
this
must,
patient.
yes. How would you?
Because
That's
10,
what I said. So you need your MGOA is very important,
yes, sir.
and you need your reflexes important, because when you assess the patient improving or not, they are the one who is going to give you the predictive science. Am I
Yes,
correct?
sir. Yes, sir.
So when you have not written on all those things, I was a bit disappointed with that history. MGO is very important. I request all the
Because
post.
10 in this patient, sir.
Yeah.
I've not written it there, but
So what was the score for this patient?
so 10, sir.
10.
10, yes, sir.
Right. So you have a very classical case who is having MGOA 10. That's about more on the severe nature, right?
Yes, sir.
Because there are much discussion about the guidelines for surgeries in cervical myelopathy. You know the guidelines?
So I've not,
What are the latest guidelines?
I've not gone through.
You have heard anything about the guidelines, the North American guidelines or WFNS Spine Committee guidelines?
So I've not gone through them.
No, you must go through.
Yes, sir.
See, you must
As-
know the guidelines.
Yes,
Of
sir.
course, this case is very straightforward, so no problem.
Yes, sir.
This case is a very straightforward. The patient is in a very severe neurological status. MJOA is very bad, so you straight away say for surgery. But if you have a different kind of cases that you need guidelines for that, please go and read. If interested, then at the end of this session, I will show you. I can
Yes,
show.
sir.
Look.
Yes, sir.
Yeah, sure. Yeah, I think you must be aware of all these because that will help you plan. Yeah.
Yeah.
Yes, sir.
All right. So, all right. Now, again, we've discussed. So now, finally, okay, you tell us what final surgery you will do. What decompression, what fixation. Finally, now we've discussed everything. We've gone anterior approach, posterior approach, decompression, stabilization levels. Tell us now exactly what you will do from what level to what surgery. Don't say laminectomy or laminoplasty. Exactly what, and from what level to what level, and will you stabilize? Just give us in a nutshell.
So I'll do C2 to C7 laminoplasty with multiple level fixation.
Not multiple level. When you operate, you say multiple level. Exactly which levels?
So
I ask you
we'll
for specific surgery now, and exactly what specific. You are now on the table. What are you going to do? Patient is prone position. You've taken. And what all will you do now?
so what all surgical steps?
Yeah, exactly. Not because we'll very briefly in the next couple of minutes, so then we can go on to further discussion. You have to describe now in the next 3 to 5 minutes your entire steps from beginning to end of your surgical procedure.
So we'll keep the
We won't
patient.
interrupt you. We will just listen. Yeah.
So we'll keep the patient prone, then give a midline incision from. We'll fix the head, and then after draping and preparing, we'll give mark an incision from C2 to C7, a midline incision, and after giving a midline incision, we'll separate the muscles from the spinous process. Subperiosteal dissection would be done, and then reaching up to the facet joint, and then we'll do for laminoplasty. We'll cut the lamina.
What will you use? You have to tell us now what you're going to use. How are you going to cut the lamina?
So with the Ronjos and Kerrison, we can cut the lamina, or we can
Not
make,
or now. Tell me what you're telling me exactly what you're going to do.
yes, sir.
What
We can,
what drill? We're not
we
going to
can,
interrupt you. We're going to listen. Then we'll discuss. Yeah.
so we can we'll use the drill to to on one side, because symptoms on left side will open from the left side only, and over the left side we'll drill the lamina, and then with the help of Ronjos we'll cut the lamina, taking care of that it is separated from the ligamentum flavum, and we'll do this at all the levels on the left side, and then right side uh, we'll uh, we'll separate it from the ligamentum flavum and and move the whole all the laminas, all the bones from C2 to C7 towards the right side, and then we can excise the ligamentum flavum. We will excise the ligamentum flavum, and then after excision, when the cord is decompressed, we will use we will do we'll place a graft between the two lamina and fix it with screws and plates over the right side, so that there is space, and the graft can be either taken from iliac crest, or it can be artificial, and then after fixing it with screws and plates, we can fix the spine. We'll fix the spine at C2, C3 level, and then C5, C6, C7 level, and then C2 level laminar screws will be there, and then pedicle screws at the level of C6, C7, and then place a rod, and then fix the spine, and then do the closure in 4 layers.
Charunesh,
Yes, sir.
I would like to, what is the name of this procedure?
Sir, open door laminoplasty is done, and then we are fixing it multiple levels.
Yeah, who invented this?
So that I don't.
I think you have to read in much depth. That's
Yes,
my advice to you is that you have to go and read more,
Yes,
because we said that you have to put implants. In how many I don't know about how many centers are doing instrumentation along with laminoplasty. Instrumentation with laminectomy is okay. What's the benefit of laminoplasty over laminectomy? What was claimed to be?
Sir, we don't have to do fixations.
Yeah, then why do you want? Because we examine as we ask, so because of that you are telling that you have to put the screw. So once you do expansion door laminoplasty,
Yes, sir.
yeah, you are supposed not to
Yes.
to take away. That's why I asked you this question. There's one more question is because see, when you said that you are going for expansion laminoplasty, what will you do with this C2 spinous process muscles? You know, they are already detached out. Am I correct?
Sir, we'll not detach the muscles attached to the spinous process.
Okay. So you don't detach the spinous process muscle.
Yes, sir.
So you'll be doing the undercut and then rotate it. At C2, because C2 you have to rotate it from. You said you are going to cut on the left side and cut on the right side. From the left side, you mobilize to the right side. Am I correct?
Yes, sir.
So what will happen to the right side spinous process muscles? Will they not pull it back?
Yes, sir. They will.
Yeah, you have to think, okay?
Yes, sir.
You have to think about these points which we are discussing now. Huh? I hope you got it.
Yes, sir.
Yeah, because it's very tough. But there are techniques which are devised to without splitting the muscles from the spinolaminar area. Just split at the midline of the spinous process and then break it up. Right from laterally, you do the guttering to the lateral. It's very technically difficult. So because of this, it's because of this, now many surgeons are preferring laminectomy over laminoplasty and then
Yes,
go
sir.
for instrumentation, right?
Yes, sir.
Because you must be knowing about so many surgeons names like Hirabayashi, and you have not heard about Dr. Hirabayashi?
Yes, sir.
Why are you not telling about anything about him?
Yes, sir.
I think you must read journals, and because you must read more in depth about when you take one subject, you must read much. You should not forget history. Every technique you must go through the history, right? So only when you read history, you will enjoy neurosurgery. Otherwise, there is no point in, because you can say laminoplasty, but you should know what technique you're good doing, or modified technique. Who found the technique? What are the benefits? What is the difficulties? Is it really needed in this case? So your depth of discussion must go to that level.
Yes, sir.
Okay. Yeah,
Yes, sir.
but technically, can you tell me about anything? You can give anything more about intraoperative neuromonitoring in these cases?
Sir, yes, intraoperative neuromonitoring will be done. SSEP and MEP must be done, sir.
Are you doing in your place?
Yes,
You
sir.
have experience on that?
Sir, yes, we do intracranial monitoring of.
Why you didn't tell about it? See,
Yes, sir.
if you are doing that, you have to tell us, because now you are the new generation neurosurgeon, right?
Yes, sir.
The new generation neurosurgeon with the armamentarium like IONM in your hand.
Yes, sir.
Now, if you have, I would like to ask a few more questions on IONM on this. When do you like to do? When do you like to start monitoring the waves?
So we'll do baseline waves starting before the surgery.
When?
So just after induction, after positioning, sir. After placement of the probes in various muscles, and before the start of the surgery, we'll do one baseline graph, and then we'll compare the graph throughout the surgery, and if there is any decrease in amplitude or increase in latency, then that is informed, and usually less than 50%, and
Yeah.
so,
No,
yes,
I like to know, in case if your waves are already down at the time of positioning. How do you know that?
sir, we can.
You have positioned. You think that you have done a very great cervical spine,
Yes, sir.
the position very nicely.
Yes,
But
sir.
how do you know that your patient was living with a kind of a posture for his comfort, right?
Yes, sir.
Now, after a GA, everything is lax. Your muscles are lax.
Yes,
Now,
sir.
would you like to do the waves before positioning the patient or not?
Sir, it should be done, sir.
You must, if you do it, when you do the positioning, you find out if the waves are changing or not.
Yes, sir.
Waves are changing, that means your position is a little bit more critical. Right? So
Yes,
without
yes.
you doing any harm, your position will do harm to the spinal cord.
Yes, sir.
Am I right?
Yes, sir.
You got the point, right?
Yes,
So
sir.
this point has to be very, very important point. So before positioning, you must instruct along with your anesthetists and also, your surgical colleagues going to turn the patient very, very gently to position the patient in prone or whichever position you like. And the neck in this posture, you can see the MRI. This is the MRI of the which probably the patient was lying in supine in this case. Am I correct? He was most comfortable position. So this
Yes.
position you put it and you see in the X-ray. You're not going to do an MRI. If you have an MRI in your setup, yes, you can do it. If you don't have it, then you have to go only with the C arm. With the patient slightly with neutral or extension. And the IYNM will give you a clue whether the position is good or not. If the position is not good, you're getting slowing, and then probably you have to readjust your spine position before you start operating. Huh?
Yes.
Alok? Alok?
Hello, sorry, I didn't realize I was muted.
No problem.
Suppose post surgery, the patient comes out and he has a neurological deficit. He's quadriplegic, for example, and in respiratory distress. How will you manage now? You've shifted the patient, and there is no movement.
Yes, sir.
How will you manage now? Tell me exactly what you will do in the intensive care. You've shifted the patient to your ICU, and patient is not moving both legs, is on ventilator. The anesthetists aren't able to get him off ventilator. Now tell me what you'll manage.
So we'll manage as it should be as a patient on ventilator first of all, because we must see that he does not develop any lung infection or any other.
अरे not develop lung infection वो तो दूर की बात है. अभी क्या करोगे यार? Patient was moving and he's quadriplegic. What are you going to do right now?
Sir,
Preventing lung infection is a long-term thing, no? अभी क्या करोगे?
so we will
Will you
stabilize.
start any medication? Will you do any investigation? Will you start any medication? What will you do?
So we'll so first stabilize the spine, then.
Despite your best surgery, ऐसा हो सकता है कि नहीं हो सकता? It can
Yes,
happen,
sir.
right?
That can happen. Yes, sir.
Yeah. Okay. So
we'll see that that spine is stabilized at that time in ICU, and
you will
no
see
more.
spine. Okay. Then
If possible, we'll repeat an MRI and then go forward with the MRI, sir. Otherwise, we have to stabilize the patient. That's.
are there any medications you could use?
Sir, for weakness, I don't know, sir.
Are there any drugs that could possibly help? Not definitely. It's a little controversial, but is there anything that you could possibly use?
So not red, sir.
Okay. I mean, if so, this is like, it becomes like a spinal cord injury, right?
Yes, sir.
I'm saying possibly. I'm saying because it's controversial and not everybody agrees it should be used. But I'm just asking you if you know of what was done in the past, what could possibly be used.
Past, sir, steroids were given, so methylprednisolone was given.
कितना methylprednisolone कैसे देते हैं? How will you give methylprednisolone if you have to use it?
So that's given 30 mg per kg. So that
30 mg per kg what? Over what?
so over we have to calculate it. Then total dose 30 mg
30
per kg.
milligram per kg. You give it over 24 hours, over 1 hour, over 15 minutes, over what?
So no, we'll give it in 24 hours. First, we'll divide it in 8 hours, and then
No, it's not like that. Bolus 30 milligram is given.
Then over 15 minutes. Sir.
15 minutes, and then you give it later. What is the dose for the remaining? 5.4 milligram per kg.
Per kilogram body weight for?
Yes, sir.
For the next 23
24.
years.
Yes, sir.
So what is the regime called? This regime is NASIS.
Yes, sir.
You have to tell, see, you cannot keep quiet. The examiner should not ask, you must come spontaneously. I would like, in case if I see this patient having a neurological worsening, I would like to start the steroid immediately as part of the benefit to the patient with this protocol, right? You consider this as a spinal cord
Yes, sir.
injury. That's what is Professor Alok.
Yeah, exactly. Yeah.
So
So consider it like a spinal cord.
iatrogenic trauma.
Sir, I thought that was controversial. That is why I didn't.
No, I mentioned. That's why
Yes,
I
sir, when you
mentioned it's
mentioned it,
controversial.
then only I.
Yeah. But would you have you seen it being used?
Not
Not much.
seen.
Okay.
Yes, sir.
Okay.
All right. Since we are discussing this, I mean, we've discussed posteriorly. I mean, I know maybe this is not the right case to go anteriorly, but can you tell me, suppose this was not so extensive and suppose it was a single level or a 2-level and you went anteriorly, all right? Can you
Yes,
just
sir.
describe the approach if you had to? How would you do it? What would
Sir,
you start from the position?
so we keep the patient supine with slight extension.
Slight
And
extension, okay.
so we cannot extend much, manipulate the spine much in this patient, but for anterior surgical surgery, we should keep the
You
patient.
keep something below the shoulder, below the neck.
Yes,
position
sir.
becomes very important in spine surgery. Yeah.
So we'll keep rolls below the shoulder and to for the extension to be there, and then we go from the
And
right
if you are
side.
doing, no, the problem was at C5, C6, what incision would you take?
C5, C6, yes, sir.
If you had to go to the C5, 6 level, what incision would you take?
So C5, C6 level, sir, we will give an incision over the below the.
What would be anatomical landmark? I mean,
so below the thyroid cartilage.
the cricoid. From where to where?
Sir, cricoid cartilage.
No, that's just a level.
Yes. So below it, 2 to 3 centimeters, sir.
No, means from where to where? From the midline, sternocleidomastoid. I'm giving you answers.
It's medial to the sternocleidomastoid.
Skin incision. I'm talking about the skin incision.
Yes, sir.
Okay, then once you incise the skin, what comes next?
So skin, then superficial fascia, then platysma will come.
Platysma, okay. What do you do with the platysma? Then you?
So we can we'll incise platysma.
Okay, and you develop a plane. Where do you develop the plane? In relationship to the sternocleidomastoid, where do you develop the plane?
So we'll keep the in the carotid artery laterally and the thyroid medially and go in between that.
Okay, all right. Then what is there some muscle that you have to is there any other muscle that has to be split till you get there?
Yes, sir.
Okay.
Okay. Now I'll go to when you come to if you have to, let's say you have reached the disc. Tell me how you remove the disc. What do you do to the anterior osteophytes? What do you do to the disc? What do you do to the OPLL? If this was a single level, I'm just assuming. I just want to have a discussion so you have both sides. You've seen anterior approach, right?
Yes, sir. I've seen, sir.
Yeah. So now you are on the spine. Next, what?
Sir, we'll remove the osteophytes. We'll drill.
Which osteophytes are you talking about?
So anterior
okay.
osteophytes. Then we'll remove the. If we plan to remove the vertebral body, then we can we can remove that with also, and otherwise we can um, so we
So suppose
yes sir.
you remove the disc first, right? You remove the body
Yes, sir.
directly. If you have to remove a
So
body, what do you do
remove the
before?
disc first.
Yeah.
We'll remove the disc in
What do you do to
after.
the posterior osteophytes?
So we remove the osteophytes and with kerosene, but we leave a layer of osteophytes over the spinal cord. So over the thecal sac, so that the dura is not teared because it is adhered to the dural tissue.
And let's say there is ossified ligament there. How would you remove that?
Sir, we will leave the
What instrument will you use? How will you remove it? Would you drill it? Would you use some other instrument? How do you remove ossified ligament if you have to do it anteriorly?
that I have not seen, sir.
You've not seen. Okay.
Not read.
All right.
Okay.
Okay, Parthiban, what else? You can go ahead.
Yeah, I think we can come to a reasonably, yes, discuss, but he has to improve a lot more in my view as a clinical, because quite a bit of improvement need to be done on Charunais. I think a long way to go. If you are a final year student, I make you very clearly that you have, during this discussion, you have seen those points which I have mentioned. Please write it down and work up on that, and on that line, right?
Yes, sir. Yes, sir.
You have to work up on that line, and more bold discussions should be done. Yeah, it is possible. Alok,
Yeah.
yeah, I think you
Okay,
want
I
to
think
say
we can hand
something?
over back to Rishabh. Rishabh, you want to invite any discussions from the audience or something? Let's keep some time for discussion.
Actually, I like to show one slide. If Rishabh
Yeah, sure. Go ahead, please.
permit on this particular subject, maybe I can show you one slide. Are you able to see this now?
No,
Are you able
sir,
to see?
not yet.
Not yet? Oh my God! One second. I'll try. They're not able to see my slides. Anyway, I'm sorry. I think that slide is gone. I'll try to show you one. It's not coming, and I'm not able to see you. 1 minute, yeah. I just wanted to out of this, since the subject is on this. Are you able to see this now?
Yes, yes, sir.
I think it's loading up, and it was loaded, but then I lost it. Because he has mentioned, but it's not much mentioned about this, the criterias, the important, like, Japanese Orthopedic Association, modified those scales is not mentioned very specifically. He has to improve on those lines, like, pre-op lines, which I would prefer to, as an examiner, I would like him to tell this, because those are very important for the doctors to assess how the patient is improving or not. So that way, are you able to see now?
Yes, sir.
Yeah, I can, maybe. Actually, I'm not. Yeah.
Yeah, you just
Are you
maximize.
able to maximize? Yeah.
Yeah.
I'm just getting it because something has happened. It was, I perfectly kept it ready, but then
Okay,
I
click
don't
on
know.
that. Yeah, open it up. Open it up. One of those files.
I opened it. It's going on, but it's not getting up.
Oh, okay. It could
So
be.
I will just wait for a few minutes and see. This is about the, yeah, I think it's, you're able to see now.
Yes.
Yes.
Yeah, see, this is what Tarun is, right? Is he there now? Yeah, Tarun, you're there.
Yes, sir, I'm here.
Now you see, this is a very important, the guidelines, right? This is the EOS by North American CSRS guideline, which made, if you see that modified Japanese Orthopedic Association to moderate to severe, you recommend surgical intervention. And the mild cases, it's very difficult to plan for surgery, but you may have to ask the patients to go through a proper physiotherapy with caution, that they may get into trouble over a period of time. So this is the one of the guidelines, but subsequently WFNS Spine Committee brought out another guideline, nothing much different, but slightly different from what was told by the earlier guidelines. So this is WFNS Spine Committee also recommended something similar. But only thing is that in few areas, particularly in the mild variety, CSM, with non-myelopathic patients with evidence of cervical cord compression without signs and symptoms, that is a patient who comes asymptomatic, but you do find a non-myelopathic patient, but there's a severe cord compression. It's a very controversial subject. Now the students must know this. The reason for that is that you do get this kind of patients which comes to you in practice when you become a neurosurgeon. But if a patient comes with a very mild radiculopathy with a severe cord compression, so you have to be in a position to tell what to do for the patient. Patient does not need a surgery immediately, but the patient has got a high risk of going for a quadriplegia with a trivial injury. So that particular point has to be put forward to the patient. And if there is a radicular pain or if there is few symptoms starting, then these patients must be recommended for a surgical treatment at the earliest. So this is the WFNS Spine Committee, the latest one. Professor Gileli is also here. I saw him here. And this is our article which we published. Right. I also encourage the young neurosurgeons to go through this guidelines as far as CSM is concerned. Now, for mild and moderate and severe, everyone knows it's very clear. The subject problem comes when it is mild. When there's a mild degree, means 15 to 17 MJOA, you tell them, don't get worried, you'll be all right, but wear a collar, be careful. Do not get into, do not go for a drive without a seat belt. Give all protection. Should be very careful, but at the same time, give a caution and get an informed consent. The informed consent is because many times patients, they refuse that the doctor has advised to you for a legal purpose. As far as the non-myelopathic patients which become symptomatic, a non-myelopathic patient comes to you for no problem, you just take up, but you find a large amount of canal stenosis, but the patient is absolutely okay. And that patient, when patient develops a radiculopathy or minimal symptoms, then they are for surgery. This is one particular thing I wanted to say, nothing else. Thank you. I'll stop sharing in this. This is for the interest of the presenter. I show this. I'll try to stop
Thank you,
sharing.
sir.
Can I make some comments?
Yeah, there. Gileli, Professor.
Hi.
Hi, Gileli.
Hello, everybody. Actually, very nice meeting, a very nice discussion. It's like making an oral examination. Am I right?
Yep.
Yeah, exactly.
Yes, sir. Yes, sir.
Okay. But I will just comment on the case. Actually, first of all, this case had a preserved lordosis. Lordosis is not lost.
Yep.
And it's a multi-level compression. So then it's, and then OPLL actually in multiple levels. And even I saw in some slides, there is some dural ossification, So in case dural ossification, anterior decompression is risky because of CSF leakage, more risky. And there is one paper from Japanese friends, Dr. Mizuno, saying that in cases of multi-level OPLL, dural ossification may reach up to 30%. Although you can protect the dura, even if it is ossified, but if you open it, then it's anterior CSF leakage is more difficult in cervical spine than any posterior leakages in other levels, because then you can cause some respiratory distress, swallowing difficulties, other things. So then I would never try to make an anterior surgery for this case. Posterior surgery is better. Besides, recent publications have shown us that if you make some sort of fusion, then OPLL can slow its progression or stop progression. So there are very nice long-term follow-up studies showing us that in case of fixation instead of laminoplasty, so then I would not prefer to make a laminoplasty in this case. I would possibly do a lateral mass fixation and laminectomy. Another thing is C2. If you remove C2, it's a very bad idea to remove C2 because the muscles attaching there are very strong muscles, and then you can you should better preserve the lamina of C2 and make under mining. I mean, remove some parts of the C2 and open the canal from there. These are my concerns. These are my comments on this case. Thank you.
It's very nice, Professor Jileli. Thank you very much. Yeah.
So any questions from the audience, Yushab?
Yeah.
From the participants?
We have had a few questions, sir. Question from Jadis was, any role of cervical CT to rule out EDH post-operatively if the patient deteriorates?
Yeah, CT, but I personally feel that you can do an MR. CT is okay, but MR will be better.
There's one more question from Dr. Malappa. In this particular case, C1 to C7 would be better as there is significant compression at C2. Kindly opine regarding it. I mean, I think Dr. Malappa is talking about the incision and the decompression part, if I'm not wrong.
As far as I'm concerned, I will do up to C2. But C2 to C7. But if I plan for fixation, then I may go one level above, because I would like to include C2 and also C1 there, because it's such a long segment. But here it is already fixed, as Professor Jileli was pointing. But here here, as far as he has not produced as deflection extension X-ray, but with whatever investigation he has shown, is more as a fixed, good lordotic spine. That's a very, very nice K positive case.
Even I think I would not do C1. I think C2 onwards would be better, and I think that's much better. Yeah.
Okay. Can I make a comment, Alok?
Hi.
Atul, yeah, Atul.
Good evening,
Yeah,
sir.
please. Atul, yeah, hi.
Yeah. So I enjoyed this discussion, and I enjoyed this initiative, and I'm sure this will give opportunity to young residents, and not, I should say, young learners and students of neurosurgery. I recently heard that nobody is old in neurosurgery. Everybody is a student of this great subject. And I have to make few comments about this case that was in the discussion. You see what, we described first in the literature, oblique osteotomies, oblique. You see, we oblique corpectomies. So what we did is we did oblique corpectomies. This I described some 20 years ago, and did, preserve the bone and remove the compressive factors and remove the osteophytes and the OPLL. So multi-level corpectomies, oblique, and by this technique, we avoided fixation. You see, only decompression was done, and our feeling was that these oblique corpectomies do not disturb the stability of the spine, and that is the reason we avoided fixation. So that was the premise that we used to follow. But what we realized, so what we are doing is, for several years, my experience with OPLL, initially with decompression from front, decompression from behind. And there were, as Alok was mentioning, that there are instances in such cases of OPLL, such severe OPLL, when you do decompression from front or you do decompression from behind, you can have a situation which is not uncommon, that your patient lands up and he does not wake up moving his limbs. He is completely zero. So that kind of experience we had earlier in my story of learning. To the extent many of you will be surprised that in KEM, there was a period of 3 or 4 years where I used to say in various meetings that OPLL is a non-surgical disease, because after suffering from many of these complications, we realized that the complications can be so devastating that surgery is a dangerous affair. So that was and as head of department of KEM, I was actually refusing for 2-3 years. We did not do. But then our learning process evolved. I am actually a little bit unhappy that the presenter, I think Tarun, his name or whatever his name, that he is presenting, but he did not see or read any recent publications on this subject. And I have to give my thought. When I am talking, I am not going to give thought of anybody else. I am going to give my thought, and which is published in at least 25 papers on this subject. And this young boy, Tarun, should have read some recent work on this, particularly when it is coming from India and when it is coming from Mumbai, his own city. To ignore that, completely ignore, is, I consider, absolutely non-acceptable. So the concept which we have proposed, and we are absolutely thrilled about that concept, which I think is a revolution in the field of OPLL and this kind of complex multi-level degeneration, that instability is the primary issue. Osteophyte formation and ligamentous flavum hypertrophy and OPLL formation are secondary issues. So the primary nodal point of pathogenesis of the entire process is multi-level spinal instability in degenerative spine and in OPLL. So what we have recently recommended, that you should treat the primary issue. So treat the primary and respect the secondary, like disc space reduction, osteophyte formation, ligamentous flavum hypertrophy, osteophyte formation. These are all secondary issues. So the recent concept that we have proposed, which Dr. Jaleli has written a comment in my article, which he did not refer, and he talked about fixation, but he failed to refer his own comments on my own paper, which I'm a little bit not too happy, I must tell you. That only fixation without decompression can be a beautiful form of treatment, And when you are sitting in Sion Hospital, you must be talking to the residents in KEM about the results of these operations. And if you are not in a good talking terms, I will give you that information that you do stabilization only without any kind of decompression can give you a magical outcome, magical. That is one thing. Second thing is being talked about C2 spinous process to remove onto undercut and undermine, and you are very happy about it. But I have to give you my own thought that many of these cases of OPLL have associated instability at the atlantoaxial joint. And atlantoaxial stabilization is mandatory in these conditions. Mandatory, you mark that word. So in the title of one of my article is that's multi-level stabilization that includes atlantoaxial joint stabilization is a revolution in the field of OPLL surgery. So what the contrary things which I am saying is, one is what C2 spinous process is part of the story, but that is undermine and undercut, those things are different. You have to stabilize C1, C2. You have to stabilize multiple joints even if there is no evidence of compression at C1, C2. So this is my concept. And I have published heavily, at least 25 articles in the literature there for you to read. So I recommend that you please read these things. And if there is a possibility of a revolution in the field of OPLL and degenerative spine, particularly in the kind of case that you have shown, you do decompression in this case, you are bound to land into a disaster. There may be some temporary here and there, and the best result that you can get in this patient after multi-level decompression and laminoplasty that you were saying, at best will be that you have not harmed the person. So if you want to cure this guy, this particular patient which you were showing, Atlant C1, C2 and multi-level subaxial fixation, I promise, and you must, when you are sitting in Sion Hospital, you must talk to the residents here in KEM. If you are not able to read and you are having some visual issues, that how are the results of this kind of operation? When you think you talk about, and even Parthiban has heard me talking, and he's failed to even recommend or even mention about this. I have a feeling it is a little bit injustice to what I have been saying in multiple forums where he has been a partner to my discussion. I think, Parthi, I want a comment from you on this issue. Yeah. Whether you agree or not, that is nothing. See, I'm not saying you agree and you follow what I have said is the correct and you should not follow other things which we have been doing. I am not saying agree. I do not want you to agree if you do not really have that, if you have not understood, you don't agree, because what is written in the AO book and WFNS, this thing, you agree to those things. You don't agree. But this is what is published on several occasions in the literature, and at least a mention can be made whether you agree or not. You can say some people or some fools are advising fixation, but I don't agree with that. But you cannot completely ignore that. And I think particularly when sitting in Sion and sitting in India and sitting in a forum where I have been party to multiple occasions and not even saying a word about it is a little bit not correct, and you are undermining the literature, not me. And I don't mind if you undermine me in any way. But literature, you have to mention that this is a new proposal and this is written in at least 25 articles on the subject. So this is a little bit aggressive thing I have said. Please don't mind the aggression. Please don't this thing. But you try to understand what I am introducing, a concept which I am absolutely convinced, whether you are agreeing or not agreeing, that is on you. I am saying a revolution is here to be made, and it is made, and it will be followed, if not today, tomorrow.
It is actually Atul. Actually, before you came, actually we had the same discussion. In this case, I told that it is the decompression with stabilization. Number one. Number two, it has to be included with C1. I think probably you were not there at that time.
Now, Parthi, I will tell you another thing. Yeah. You see, this decompression with stabilization is also a concept which is recent. which was not followed earlier. And I have to say that this decompression plus fixation is a concept which people are talking after reading my articles. Like even Jaleli mentioned that I will do decompression and fixation for OPLL in this case, which he was not saying earlier. You see in his own articles, I will show you, in his own WFNS recommendation, which authored by Jaleli, he said decompression. He is saying fixation only because he's influenced by my articles. And I am sure he will accept it.
Yeah, see, this point, this is what I was discussing when we were discussing this case. I am particular about this patient to be fixed because a person, if not only have to C2, C1 must be included in fixation. I think that was the real one. I agree with you. The instability is the one which causes all this osteophytes and all those. So once you stop that,
Bharti, you are saying instability is causing, but this concept has been introduced by me. Why don't you say this? Why means why? What is the harm in stopping halfway?
No. We agree with you.
You agree? Then say. Then
Yeah,
say
but
that you are a respected member of the field, and you have heard me talking on at least 20 occasions on this subject. But why are you hesitant to say? And when it comes to failing, and when it comes to anybody else, you are very loudly saying. But when it comes to something which a person of you know him so well has introduced, you are a little bit hesitant to say. Why is that?
No, I'm always very proud to say, Atulji. Come on.
So
Anyway,
say that. Say that.
yeah,
Don't
I'm
worry.
very proud.
So with those few words, I am
Yeah.
here to say that you are all my friends. My most dearest friend is Mehmet Zeleli. He knows we are together in various forums on spine, on various issues, craniovertebral junction. We are together. There is no, we are working on a subject where patient is the king. We work for the patient. We are made by the patient, and we work in the interest of the patient. And we should, one thing is for sure, we should be open to ideas. We should be open to thoughts, and we should be open to something which is different from the conventional. This is what my purpose is for the young people. You see, this is I never talk like this, what I'm talking like this. I don't talk in meetings like this. I don't argue with people like this in the meetings. But we should be open to ideas. We should be open to concepts which are different. And somebody is talking so proudly and so loudly, and this thing, there is no harm in acknowledging that.
We are always proud of Atulji. No problem. See, I tell you one thing. See, this is the concept which we have been doing it for a long time, stabilization concept. And you made it very firmly. Actually, you raised the voice and saying that if you do stabilization, quite a lot of spinal problems get settled down. It's true. In fact, that is the concept of the fusion itself. The concept of
We
fusion
should
itself.
also, you know what, I will tell you, Parthi, the existing literature says, now it is for the young residents who are listening and the young students of neurosurgery. The existing literature on the subject says, when you do multi-level laminectomy, when you do multi-level corpectomy, you are iatrogenically making the spine unstable. This is the concept, this is the literature, this is what is mentioned, and that is why fixation is done. I am saying that instability is the nodal point of pathogenesis of the entire process of spinal degeneration, entire process of OPLL. So this is fixation which I am recommending, is not the fixation which is conventionally mentioned or discussed or agreed upon, that iatrogenic instability is the cause of doing fixation. So that is the difference. You agree, Parthi, what I'm saying?
I got the point. I got the point. What you're trying to do, put it forward to the world of neurosurgery, is that instability is the one which creates these osteophytes, the OPLL formation. In fact, I agree with you one thing, that even after decompression, the OPLL continues to grow. The reason for it grows is there's a movement. Stop that. I know that this concept of being there with you, and you have been telling this for a long time.
Now, the
I
other thing
strongly
is,
agree with
Parthy,
you. I strongly
thing-
agree with you one thing. The students, they are not going through the literatures. So the reason why I showed the last three guidelines itself is for that only, because they have no idea. And
So
if
the
they have
other,
gone through the literature, and all these discussions will come in. I strongly agree with you. And I know that you are one of the best friends of neurosurgeons, and your points are always enthusiastically
yeah.
taken care.
See, the
Yeah.
other thing which I want to, you see, these young people are sitting. The youngest is, Parthi, and the youngest is Mehmet Zileli.
Mehmet Zileli.
And youngest is me. So I invite the young people to read a very recent article published in World Neurosurgery just few weeks ago. You go to World Neurosurgery and read. I have written a recent beautiful article on a basis of a very big experience of the status of osteophytes after only fixation. You fix only, don't do decompression, don't do laminectomy, don't remove. And you read that article, I have stated that you do only fixation and the osteophytes automatically disappear. That is the recent article you must read. So you go, if you realize the entire neurosurgery, entire spinal neurosurgery is based on a concept that osteophyte is pathological, osteophyte is compressive, osteophyte is the culprit. So the whole operation is based on working interbody to remove the osteophyte or to do corpectomy to remove the osteophyte and to, essentially, or to do laminectomy to accommodate osteophyte. The whole spine surgery, the entire spine surgery is concentrated on one issue to remove the osteophyte. I am putting forth an idea. You don't agree on it. You completely disagree on it. That osteophyte is an indicator of spinal instability. One issue which Parthiban was discussing, that if the patient is having no symptom but a big osteophyte, what is your interpretation? The interpretation is the instability is settled, whether it is symptomatic or not, and that instability is indicated by the osteophyte. Osteophytes, disc space reduction, ligamentous buckling, ligamentous hypertrophy, facetal listhesis, spinal canal reduction, intervertebral foraminal reduction are secondary issues to primary spinal instability, which is not due to disc degeneration, disc space reduction, or reduction in the water content of the disc. It is due to your own problem that you have not exercised your back muscles. You have not exercised you have not jogged like Professor Ramani is doing at 85. You see his neck muscles and you see his strength of his spine. Because you don't exercise, you get vertical facetal instability as the primary issue. From there generates, or their blast of spinal degeneration occurs. Disc is not the issue. Osteophyte is not the problem. It is a solution which God introduces. They are protective. They are not harmful. They are protective. Problem is one. Either you have the power to strengthen your muscles of the neck and nape and the entire extensor compartment. If you realize the whole body, the muscles are in the back. How many muscles are in the front in the region of the disc? There is not a single muscle. The muscle longus colli is intervertebral, very thin, flimsy. All the muscles are back. All the muscles are acting on the facets. Disc is a divine structure. Disc is not the problem. Disc is always a solution. Identify the problem, treat the problem, and respect the solution which God is introducing. That is my concept. And this is a thing for the young people, not to just say, yeah, I agree, and I agree, to think about. You think about it, what I'm saying. You think about and also read and also discuss with your fellow residents in this hospital and see what they say, whether they agree or not. I am having for last 10 years more than 350 international fellows who have visited me and seen this work. And when international person can come, a person from 1 kilometer cannot come. That is the irony of the whole situation. And to that extent, that even mentioning is felt like degrading your own self. That is my real issue. And but no harm done, no bad feelings against anybody. Take it easy, relax. Best wishes to you. There is one international fellow in the audience. I can see him on the screen. Abdul Rahim is on the screen from Egypt. He was my international fellow. Abdul, can you make a comment? He's my international fellow, one of 317 international fellows in last 10 years. And Abdul Rahim, I see him on the screen. I wish from Turkey, from Mehmet Zaleli's, backyard. Let us see what Abdul Rahim is saying. Abdul, please go ahead if you can hear me.
I think he's coming, guys.
I see you. I see you, sir.
Yes.
I hear you. I hear you, sir. I am Abdul too.
Yes.
Abdul Rahman, sir.
Oh yes,
Abdul Rahim.
Yes.
How are you, sir? How are you?
Yes, Abdul. I thought you were Abdul Rahim. Abdul Rahman, you also visited me, right?
Yes.
Yes. If you have some comment, you can please make. I know you visited me, but for a very short period. I thought you are Abdul Rahim.
Yes. Yes.
Anyway.
Would you like to make a comment?
Anyway.
But it's a good.
Can I add?
Please.
Please.
Very nice discussion. We've taken all the points in the right way, and we as is said, it has to be, the literature has to be respected. That's the final. That's what literature has to be respected, and we have to rethink what the concepts are coming up, and that is what Atul is trying to tell all of us. When we are not very strong to say a few things, Atul says that this is what you try to rethink and say this is, and see that in experience. Atul, believe me, I'm a very, very strong believer of conversation, like you. So I always enjoy, we know that. But maybe this is what, when I discussed with this case, I was telling Karun that this patient needs stabilization.
Parthi, another thing I would like to say.
Please, can I add a comment?
Yeah, please.
Go ahead, Said.
Who is going
Yes, thank you, Professor Atul. I agree with you for oblique lateral approach. It's used from about 13 years, but it's not necessary to leave to take off the calcification, because it's very dangerous. It's necessary to go more lateral to the calcification of in case of OPLL. We have many cases of OPLL in Radiological Islands, French departments, and with a follow-up of about 25 years. And in some cases, the canal, the dimension of the cervical canal is very narrowing, but the importance is the clinical aspect. It's very important. Radiological aspects not necessarily important, but clinical the clinic is very important. The second point, it's about osteophyte. Osteophytes, it's possible that the calcification posterior and in front of the disc is disappeared after fixation, but osteophyte is the modelage of the vertebra. It's the transmission of the contents by annular disc. It's hard. So we can see the cervical cervical as the dynamic point of view, or no, and no static condition, but in dynamic condition. I agree. It's not necessary to operate all the OPRL because they are very risky, and the fixation can be a solution in the case of OPLL, especially in superior part. That's all. Thank you.
Okay, so one more message I want to give to the young students of neurosurgery. The title of this webinar is For the Residents and By the Residents.
Yes.
And I want to give a very good message to the residents that when we come in the field of neurosurgery, we have to come with open mind. You should say that I have not come to answer your questions, but to question your answers. Did you get my beautiful sentence?
Yes.
I have not come here, John Bennett, you listen to this.
Okay.
I have not come to answer your questions. I have come here to question your answers.
Mhm.
All the residents of neurosurgery should have open mind. They should be open to ideas. They should be open to thoughts. The mind should be supple and moldable. There is one person in the audience is right that this is not discussion for the MCS student. This is not discussion for MCS student. I am surprised. You see, this is the discussion where a young mind can be molded. And these young minds are no ordinary minds. They will not be molded by stupidity. They will not be molded by idiotic sentences. If there is some worthwhile thing, they should think about it. So you should be moldable. You should be, if you think there is some new idea that you are observing, you should immediately publish it. For your information, publication is the only way you can express yourself to the world. You should never undermine the importance of your own personal publication. You will be in the business only if you have published. So you must think about the subject of neurosurgery. Keep your mind moldable. Keep your mind supple like a young, little, beautiful person. Walk like a strong man and be open to ideas. Don't discard the ideas like rubbish. And if anybody in the audience is discarding what I'm saying like a rubbish, I think he is doing injustice. No, nobody can touch me. He's doing injustice to himself and to his patient. At least he should be able to think about. At least he should be going and reading what I'm saying or what others are saying. I'm not saying I'm this and that and you should follow me and all. No way I can say, nobody in the world can say like that. But you should be open to ideas. With those nice little words, I say thank you, and it was my great pleasure to participate. And I wish this young boy, Rushabh, I think his name is, my best wishes.
Thank you,
for
sir.
continue. What is the name? Rishabh.
Sir.
What? Rishabh.
Yes, sir.
Yes. So this young boy, right from the day you wrote to me, I said, yes, I'm with you and I will be with you with great pleasure and honor. You have to promise me that you will smile, you will laugh, you will enjoy, and you will learn this great subject of ours, great subject of neurosurgery, where we are students and disciples of God in the service of our patients. Thank you very much, my dear friends.
Thank you.
Thank you very much.
I'd like to thank Professor Goel for gracing the occasion. Final comments, if any, from Professor Parthiban or Professor Alok Sharma, and we'll be winding up.
No, I think it was a great discussion. And I'm in agreement with Professor Atul about keeping a mind open. And I've always believed in that, especially the younger generation. And both him and me had a common teacher who stimulated us, Dr. Manu Patari. Atul, you agree? He's one person who said never, always question the written word. And he was a common teacher to both of us. And he always said, question everything, question
This
everything.
is what the sentence which I said, Alok, was his. That
Yeah.
I have not come to answer your questions.
Yeah.
I have come to question your answers. This is Dr. Manu Kotari's sentence.
So we have a common teacher. We believe in questioning, and So I think if just that message goes to the younger neurosurgeons, that itself is an amazing message. Listen, keep your eyes, ears open, keep your minds open, and maybe one of you here will come up with something completely different, and we'd be very, very happy to, accept that and be open to that. So it was a good discussion. Rishabh, thank you very much. I think you're amazing. This is a good forum, and it will help all the students to overcome their fears and doubts about presenting to all of us. Thank you very much. Yeah.
Thank you, sir. Thank you, sir.
Rishabh, and actually it's a wonderful time, and actually it's a good start. A firing start. It's like one of the best start, and particularly my friend Atulji is me and him with 30 years we are together. 30 years. We have traveled by bus and we discuss so many things. This is wonderful, actually, discussing with the young generation, presenting a paper. But one thing which is said, important thing is that not come to the presentation without reading much about the literature. So that is very important. See, that's what I was telling about, that if you don't know the history, there is no point in becoming a neurosurgeon. There's no point. Because the history is far, far wide and it is depth with full of knowledge. And it's not only from us and from very close by, we are very next door, and you have to read a lot. And before you come for presentation, because here in this forum, you have such a beautiful time frame. You're giving a subject and you're presenting. And if you don't come prepared, then it is not good. Like Tarun was telling that he has not told about K-line. He has not mentioned about MJOA. He didn't talk about anything of the guidelines. Like he said about stabilization, the concept of stabilization, the concept of fusion, the concept of decompression. So I think that the student, the next time when he's going to present, must come with this. So this presentation, the whole 2.5 hours we have spent with Atul firing at the last period, it's very beneficial to everyone. Now we are all students only.
Well,
when we give answers, we get the questions. So we also learn from them. And best of luck and all the best. And we see more young generation students to come and present, and more here. And younger people like us also, we will also join for discussion.
Well, I think we'll take your suggestion, and perhaps Dr. Chetta, before the next presentation, we'll have, a list of publications or something that they can read before the presentation. What do you think, Dr. Parthaban?
Yeah,
that's a good idea.
I agree with that, because see, this subject is one of the best subject, I tell you. Cervical spondylotic myelopathy is one of the best common subject every other day the neurosurgeons see. And if you don't read the latest article, you don't read at least for 3-4 years article, and there is no point in presenting. So we'll make it as a criteria. Let it be a criteria that the student who is going to present in the next any subject for that matter should have at least a good knowledge about the last 5 years of publication or last 1 decade of publication.
Yeah, and they can share they can share what articles maybe should be read.
He puts forward with this, sir, I will do like this, sir, I will do like this. This is being debated. This is the new concept. You said that. You said like Atul was telling about it. And where you think that you have a cancerous bone next to your discectomy site. And why do you think about iliac crest? When I presented that, Atul said that you have something in your brain that you take the cancerous bone very close to the vertebral body and place it into the disc space. You swap the bones, and it's a beautiful fusion occurs. I know that when he saw that in Korea, he said that. That's a beautiful, it's a simple concept. But everyone should read where the publications are done, where the presentations are being done. So the next presentation when the student comes, and let it be as a standard that they should come with well-prepared, the latest articles published.
Okay.
And so that the presentation becomes better and better.
Okay, we'll take that suggestion, and go ahead, Dr. Chetta. You want to say something? I'd like to say something. Well, it's always good to see Atul. He's like the Elvis Presley of Zoom. People follow him where he goes, and his advice is excellent. Questioning the answers, that's exactly what Dr. Parthaban was doing, and I admire the way he was, keeping on top of the students or the residents and making them think. And this was one of our best webcasts, Dr. Parthaban, we've had as far as interactivity, I think, and learning. And okay, Dr. Chetta, do you have something that you want to part with?
Yeah, I think everyone, I mean, this forum is pretty young. As Professor Goel said, our mind should be supple. We are still innovating with our techniques of presenting. This is a learning platform for everyone. Our presenter today was from AIIMS Jodhpur, and I think that is the purpose of this forum. It is to understand what protocols are followed in different hospitals and to learn from them, and eventually innovate yourself so that it is for the betterment of the patients and not for the surgeon himself. So these are the learning days for residents in all, and this is, I think this platform would provide a fantastic learning experience to all the residents, especially the exam going ones. Not only the exam going ones, but especially the exam going ones, helps them to innovate with their case presentations for the final exams. At the same time, makes them think about what is exactly going through the examiner's mind and how to go about it. As Professor Parthiban had interrupted while saying that it should be you to speak, not us to ask. So I think the few take-home messages. For the next session, we'll like to innovate by introducing a few papers. We'll read up a few papers. I assure the panelists all about regarding that. If there are no comments, I think we'll wind up. I'd like to thank Professor Deepak Jha, HOD from AIIMS Jodhpur. I'd like to thank Madam Abida Shah for joining in. Professor Aif Cherian, who would locked in again and is, I think, out of range now. Last but not the least, I'd like to thank Professor John Bennett for giving me a platform to have this webcast telecasted.
Okay, excellent start. Excellent start. And we'll have a reading list the next time, okay? Well, so people can do their homework before and be prepared for the next presentation at the same time, same channel.
Yes.
Oh.
And a major thanks to Professor Alok Sharma for giving me that push, and Professor Parthiban for always being there and being as humble as the person he is. Thank you very much. I think let's wind up if there are no questions.
Okay. Thank you, guys. Go ahead, Doc. Okay, thank you very much, everybody. We'll see you next week.
Bye.